We'll start. Good evening, all. It is nice to welcome all of you from the temple town of Udupi for the 11th MANIPAL Cardiology Update, which we conduct every year on November 1st. As you all know, because this is special social scenario because of the COVID, we are conducting e-webinar as is being conducted worldwide nowadays. Before we start the program, I would like to join all of you to listen to the inaugural speech by our respected Pro-Chancellor, Dr. H.S. Ballal.
My dear friends, I am happy to participate in the 11th webinar-based Cardiology Update 2020. I congratulate Dr. Tom Devasia, our dynamic head of the Department of Cardiology, who is also the organizing committee chairman of this conference, Dr. M. Sudhakar Rao, the organizing secretary, and all other members in the team for conducting this very important conference. This has become an annual feature now, which is very important to keep yourself updated in the recent advances in cardiology. Mahatma Gandhi has said, I quote, "You live as if you are going to die tomorrow and learn as if you are going to live forever." Our Prime Minister Shri Narendra Modi ji has said, we now live in an age where change is constant and we are variables. Change is the only constant, my dear friends, and to keep up with this change, learning should not be seen as an end, but as a means to achieve the greater heights in life. You should continuously update yourself with the latest technologies, innovations, and changes the world around going through. Kasturba Medical College is the flagship of our university. It is the first self-financing medical college to be started in our country by our founder, the late Dr. T.M.A. Pai, way back in 1953. Our medical college was the 29th medical college to be started in this country. Today, we have more than 500 medical colleges in this country, and I am very happy and proud to say that we are consistently ranked within the top 10 medical colleges in the country for more than 2 decades. Department of Cardiology is one of the most important departments of our medical school. MAHE has been conferred this year Institution of Eminence deemed to be university by the Ministry of Human Resource Development, Government of India, about which we are very proud of. The theme of Cardiology Update 2020 is What is New in Cardiology? I am told that reputed cardiologists from all over the country are participating in large number in this conference and are making presentations. My warm greetings to the guest speakers and all the participants. This update is mainly focusing on the latest guidelines in the management of coronary artery disease patients and the latest in scientific advancement for catheter-based aortic valve replacement, latest medications, and the latest in pediatric cardiology management using stents as alternate to surgery, and the new trends in heart failure. With these few words, ladies and gentlemen, I have great pleasure in inaugurating this web-based Cardiology Update 2020, and I wish this conference every success. Thank you very much for the opportunity.
Thank you, respected Pro-Chancellor, for your wonderful inaugural speech. Yes, we all feel honored to be part of the team, to be part of Manipal Academy of Higher Education, to be conferred Institute of Eminence scale. Thank you very much. Let us move directly to the first session, first talk by Dr. Ajit Mullasheri from Chennai. We would like to invite him to talk on the topic Aspirin in post-PCI patients. What are the lessons learned based on new trials? Dr. Ajit Mullasheri.
So today we will be talking on current state of aspirin, primarily in secondary prevention, but I'd like to also touch upon a few slides on primary prevention for cardiovascular disease. So aspirin, as you know, has evolved in multiple areas, both for primordial, primary, secondary, and tertiary prevention. And we see it's quietly changing its profile in the use for treatment of cardiovascular disease. So in 1997, there was a Lancet article which showed the 100 years of aspirin. It started as an anti-inflammatory drug and moved towards many other conditions of cardiovascular and cerebrovascular disease. And you can see that its turnover in millions of Deutsche Mark was about 1,000 in 2005. So aspirin has a huge history, and it's very difficult to think that aspirin will not be used in certain areas for cardiovascular disease. So this is the aspirin trial, which made it very important for us to understand that aspirin is important for cardiovascular disease protection. And this was the preliminary findings of the aspirin component of the physician's health study, which showed aspirin was useful in reducing predominantly myocardial infarction, fatal and non-fatal. Now, the history of aspirin for the prevention primarily of cardiovascular disease has undergone a lot of trials and a lot of studies, but the three important studies we will have importance today is the ARRIVE, the ASCEND, and the ASPRI. And when you put the meta-analysis of all these studies together, what it shows simply is that, yes, it reduces some vascular events, but at the huge cost of stroke and bleeding. And that's why, in general, in the decisional pathway for the use of aspirin in primary prevention, answer is no, that you don't use it. You may use it only in a group of 40 to 70 years old who have been explained the risk of bleeding when you are taking this drug, and whose treatment of cardiovascular risk factors is being aggressive for a high-risk category. Most of the other groups of patients, you have to be careful in prescribing aspirin for treatment of as primary prevention for cardiovascular disease. So it's very important for us to understand this when we look at aspirin in today's contemporary use. So as I told you, the ACC-AHA guidelines on the primary prevention for cardiovascular disease is more or less clear. That we are now talking about aspirin usage, low dose. It may be considered only for the primary prevention in select adults of 40 to 70 years of age who have a high risk of ASCVD risk, but not at an increased bleeding. That too, the evidence is 2B-A. Most of the other conditions, either it's more than 70 years or less than 40 years, you would have a class 3 indication for the use of aspirin. Even for diabetes, unless it's at very high risk, the level of evidence is very soft, it's 2B-A, and most other groups of diabetes, it's a class 3 indication. Now, the importance to understand is even normal people have risk of bleeding, and antiplatelet therapy, especially aspirin, could increase the risk of bleeding in these patients who are elderly. For example, in women who are age 70 to 79 years, there's a 5 bleeding events per 1,000 person years in normal people. So aspirin for primary prevention generally is only for patients who are between 40 to 70 years of age at high risk of cardiovascular disease and at low risk of bleeding. Well, the story is different if you have a secondary prevention where you have a history of heart attack, stroke, coronary artery bypass, or stent, where it's clearly indicated. And you should not take aspirin if you're healthy, over 70 or under 40 years, or if you have an increased risk of bleeding because of a medical condition or any other medication which is causing it. Now, the use of aspirin for reducing vascular events in secondary prevention has again been a long history, and this is another nice paper which came with the ATT group, the anti-trialist collaboration, which clearly odds reduction in all groups for all sorts of secondary prevention shows aspirin favorable than the placebo control. Now, the next issue is that can we drop aspirin? And this is because of the increased risk of bleeding associated with the DAPT regimen. And this is a paper just recently published in September of 2020 in the Circulation, which clearly suggests that could we drop aspirin. And the reason is, the sharper the knife, the more chance you will cut yourself. So the more stronger your dual antiplatelet therapy, the more chance that you will sort of end up with a bleeding issue. So I think that this is extremely important for us to realize that patients who have an increased antiplatelet therapy have an increased bleeding risk. So is the use of lifelong aspirin in prevention of chronic coronary syndromes, especially in patients who've had intervention, still sacrosanct, or is reprisal warranted? Now, as we said, in the secondary prevention trials, with the historical trials of aspirin after MI, it clearly showed that aspirin was important for reduction of serious vascular events and death in many of the trials. And again, when you look at this, you look at the secondary prevention trials, and you can see again clearly that this is the same story that we're getting in, that your secondary prevention trials are always showing much better difference of events as compared to the primary prevention trial. So clearly, we are in a situation now to say that for secondary prevention trials, aspirin was important. But the recent trials have suggested whether we can discontinue patients post-PCI adapt among chronic stable patients, especially who are on the better antiplatelet therapy, better therapies including oral anticoagulants, especially if their bleeding risks are higher. And contemporary therapy is now very, very clearly moving away from removing aspirin from lifelong treatment for chronic coronary syndrome. So I think we have the historical aspirin trials here and the lifelong aspirin trials here, which is now being sort of questioned, and we may have this house collapsing soon in terms of the current trials which are now available. So there are numerous of these trials, and I'll go through them very quickly. But most important to say is that there was this trial, the Global Leaders trial, which compared ticagrelor for 1 month, followed by ticagrelor, dual antiplatelet for 1 month, followed by monotherapy for 23 months, showing that the events were better with the ticagrelor arm. The STOP DAPT again showing that for non-inferiority, it was superior. And clearly you can see that the STOP DAPT trial also showed that aspirin may be dropped. Both arms got ticagrelor and followed up with standard of care. And what important happened was the primary endpoint of bleeding was looked at, and ischemia was also looked at for the non-inferiority hypothesis. And clearly what you can see clearly here is if you look at the red arm, ticagrelor with aspirin had more bleeding than ticagrelor alone, while the follow-up with standard of care showed equal bleeding. So clearly this is important for us to understand. What was also important was that the ischemic events were no different whether you gave them ticagrelor and aspirin or ticagrelor plus. So a single antiplatelet strong like ticagrelor seems to be doing its job. Now, the more important thing we have to understand that these were patients with high risk events, PCI, who were taken up for this trial, and an antiplatelet therapy of a single antiplatelet showed substantially less bleeding with ticagrelor than aspirin. And it also did not increase the ischemic events up to a period of 1 year. What about diabetes? Similar results. And you can see that the death MI stroke were no different when you gave ticagrelor for an aspirin for 3 months and then followed it up with ticagrelor and aspirin versus ticagrelor and placebo. No difference in events in terms of death MI and stroke, but the bleeding was very, very significant. So clearly, what it's again showing the same story. And this is also in patients who have a high risk complex PCI being done. Again, similar results, and almost in each cohort, we are seeing a consistent result that there is more bleeding if you use 2 antiplatelets and no difference in ischemia. So this is the recent trial, the TICO trial in STEMI patients who had PCI and ACS patients who had PCI. And again, the same story that you can discontinue your aspirin after 3 months, and ticagrelor monotherapy seems to be good enough, and it seems to be better in terms of bleeding rather than using dual therapy in patients with PCI and ACS patients. Now, what about Rivoraxaban? It also shows that in patients who have chronic stable angina without AF, you can use anticoagulant alone. And here you can see this trial, the COMPASS, which showed that as compared to aspirin alone, Rivoraxaban alone and Rivoraxaban low dose with aspirin was superior in terms of outcomes in the long run. So the risk reductions were much better. And you can almost think that you can do away with aspirin if you don't want it to be used either in isolation or in combination in patients with a high risk or chronic coronary syndromes. So if you look at the ESC guidelines this year for non-ST elevation MI, it's basically whether you have an increased ischemic risk or you have increased bleeding risk. The more bleeding risk you have, you use shorter dual antiplatelet therapy and you continue a single antiplatelet. Here's a very high risk bleeding, so you would not use ticagrelor, you would use clopidogrel. On the other end, if you have a middle group of patients who have bleeding risk and ischemic risk, you would use aspirin and clopidogrel, and you could use aspirin in the long run, but aspirin and clopidogrel will be for 3 months. So you're now using this first 3 months window for patients with a high ischemic risk to cover that ischemia and then follow it up with the aspirin alone. But if you have patients with a high ischemic risk, then your drug changes here after 3 months becomes stronger, which is ticagrelor, or you can use aspirin or ticagrelor after 6 months, or ticagrelor or placebo. This depends on what you want to use and how old the patient is. And extremely high risk patients, you can use aspirin plus Rivoraxaban for 12 months and follow it up with either Rivoraxaban alone or Rivoraxaban aspirin. What about AF patients? In these patients too, we have to understand the moment you have a high bleeding risk, the first drug that you throw out is aspirin. So the moment your first month is over of PCI for non-ST elevation to AF, you simply shift to dual therapy, that is NOAC with single antiplatelet therapy, and then NOAC alone after the long-term treatment. So clearly we are moving towards a scenario where aspirin is getting dropped. So my take home here is that current guidelines recommends lifelong antiplatelet therapy for aspirin for secondary prevention. This is based on historical trial data, but emerging theme from recent trials show that with aspirin discontinuation, there's decreased bleeding and no compelling evidence for excess ischemic risk in selected groups of patients with chronic stable angina. But obviously, you should understand that you have to use the alternative, more expensive antithrombotic agents when replacing aspirin with alternative, more expensive antibiotic. Remember, the economic implications, especially in a country like India, have to be kept in mind. Thank you very much.
Thank you very much, Dr. Ajit Mullasheri, for the wonderful and detailed talk on aspirin. I would like to ask you a real-world experience scenario. Let us say after all these new trials have come, now in your clinical practice, can you tell us 1 or 2 scenarios where you would take the patient off aspirin, and what are the factors you would consider when you take it out, or what are the alternate therapy you would institute? Maybe an outline of 1 or 2 scenarios which commonly you have come across, other than non-clinical.
So I think, thanks, Tom, for inviting me, and this question is very important. So you really, in any clinical scenario, weigh the bleeding risk versus the ischemic risk. But the problem is, many patients who have increased bleeding risk also have increased ischemic risk, and that is very important for us to understand. It's not very as simple as what we talked on the slides. But for a simple reason, I have an 85-year-old gentleman who comes in for a PCI for non-ST elevation MI. So this gentleman is likely to have some surgery in the near future. He's likely to bleed somewhere because of his age, because of his bleeding risks. He may have a prostate. He may have something else to be done soon. So in that scenario, you would like to limit the duration of antiplatelet therapy. So you'd like to do a good procedure. Definitely, you like to put in the best drug-eluting stents. You like to possibly image the patient so that we are sure that we got a good result on the table. And then at 1 month, see if what we need to do. And there, in a scenario like that, I would use aspirin and clopidogrel, not even ticagrelor, because the ticagrelor will increase the risk, and drop possibly aspirin at 1 month, and then continue the patients on clopidogrel for the longer period of time. So this is one clinical scenario. Then another extreme case where you see you have a 50-year-old gentleman who comes for a PCI for again a non-ST elevation MI. He has multiple stents. He gets a left main. He gets long stents in, and he's got multiple areas of territory which are ischemic. Here's a guy who's not got much of a bleed risk because he's young. He's not had bled in the past. And here is an issue where the ischemic risk will override the bleeding risk. And if I have, say, a bifurcation stent or a left main bifurcation, the guidelines say you can go up to dual antiplatelet beyond the 1 year, not even in 1 year. You can go up to 2 years is what the bifurcation club now suggests. So there are clearly issues where we need to weigh in and decide what you're going to use for patients. So the lesser the bleeding risk, the stronger the antiplatelet therapy you use, and maybe the longer. The higher the bleeding risk, the shorter the dual antiplatelet therapy, and drop aspirin as quickly as possible and use the second agent, possibly, which is least bleeding.
Thank you very much for that answer. Just one more last question. Does the choice of stent differ in high bleeding risk patients for you?
Yeah, so if you ask me, really, most of the good third generation DES, which currently we use, are pretty good. But the data is with few stents, I have to say, because they have been studied in these areas. Each stent has its own trial. You have the Ultimaster stent, which is the Master DAP trial. You have the Zines 28 and the Zines 90 with the Zine stents. You have the entire group of the biodegradable stents like O0 in the AMI trial of O0, again short DAPTs. You have many of these new drug-eluting stents. The LEADERS trial was one of the other trials which had a very good stent showing extremely low bleeding risks and extremely low ischemic risk in patients who have high bleeding risk score by a precise DAP score. So again, the same question arises that you use your scores, you use your age, you decide that the patient has got a high bleeding risk score, you use one of these good stents which are being studied and used, and then shorten your DAPT according to the clinical scenario. In chronic stable angina, there's no much confusion. 1 month is good enough in high bleeding risk. But in an ACS patient, well, the data is more up to 3 months. We have to see for the newer trials to show that in the whole group of ACS, we can reduce it further.
Thank you very much. Warm regards from MANIPAL Cardiology Update Group. Thank you very much. Let us move next to our next topic and next speaker. Dr. C.B. Ponde will detail us with regards to the ischemia trial background, and we welcome Dr. Ponde from Mumbai for his talk.
Good evening, all of you. I profusely thank Dr. Tom Devasia and Dr. Sudhakar Rao to invite me here for this cardiology update at MANIPAL. My topic is ischemia, international study of comparative health effectiveness with medical invasive approaches. As you know, ischemia trial has been the topic of controversy, focus, interest by both invasive cardiologists and by the clinical cardiologists. How do you apply this trial in our real world clinical practice? And trust me, I'm going to play both the roles here as a clinical cardiologist and that of an invasive cardiologist and see what do they think about this trial. I may play even the devil's advocate for all you know. Invasive therapy in this trial was invasive angiography with coronary angioplasty or bypass surgery. The real question of ischemia was in stable patients with at least moderate or severe ischemia on a stress test. Is there benefit to adding a cardiac catheterization and if feasible, a revascularization by optimal revascularization strategy to optimal medical therapy? The critique of the previous studies were overruled or were negated in this trial because in the older trials, as you know, patients with milder ischemia were included, and that was a criticism of a COURAGE trial. Then there are some trials in which randomization occurred after the invasive angiography, which created a bias. And in some trials, first generation DES were used, in some trials BMS were used, and that all created a confusion between establishing superiority of invasive therapy over optimal medical therapy in patients with chronic stable coronary artery disease. Ischemia as a design overview. Please remember, there was not a single patient in this study whose coronary anatomy was not known. Every single patient, like 73% of randomized patients underwent the CT coronary angiogram. The remaining had either undergone coronary angiogram, invasive or CT in the previous year. So every single patient, the coronary anatomy was known. So stable patients with moderate to severe ischemia by nuclear perfusion imaging along with symptoms or a positive stress test were blinded, and where a blind CC and CT angiography was done. A core lobe anatomy was deciphered, and then they were randomized to invasive strategy versus conservative strategy. The primary endpoints were time to cardiovascular death, hospitalizations, MI, and heart failure hospitalizations and resuscitated cardiac arrest. The major secondary endpoint was the quality of life, which was a separate presentation, of course. If you look at the eligibility criteria, the major exclusion criteria was more than 50% stenosis in an unprotected left main coronary artery. That was an exclusion. But my friends, even there were more exclusions. NYHA class 3 and 4 heart failure, unacceptable angina despite optimal medical therapy, that is severe angina, uncontrollable angina despite medical therapy, ejection fraction less than 35, acute within the previous 2 months, PCR CABG within the previous 1 year, and EGFR less than 30, or patients on hemodialysis were excluded from this trial. So 26,000 patients with preliminary screening were enrolled. These patients, when they started screening them, 47% met clinical exclusion criteria. So out of this 26,000 patients, 47% were excluded by clinical exclusion criteria. Another 11% not enough information to determine eligibility. 2% went straight to cardiac cath by their own choice. 2% could not contact, and 6% unknown reasons. They were all excluded. So only 32% of these 26,000 were considered for this enrollment. When they were enrolled, there occurred screen failure in another 3,300 patients. Main reason: insufficient ischemia on nuclear testing, non-obstructive coronary artery disease on CT angio, or unprotected left main disease. So finally, out of these 26,000, only 22%, 5,700 were enrolled, invasive and conservative arm. In invasive arm, by 5 years, almost 80% underwent either a PCI or a CABG. In conservative arm, almost at 5 years, almost 26% landed up in having a invasive strategy or a revascularization process. Now, what does this mean in Indian context? Now, this is the data from the NIC of India last year. Look at our country. Our country, the main indications for PCI are STEMI, primary PCI, post-MI rescue angioplasties within 7 days, 8 days, 10 days, 14 days, unstable angina, cardiogenic shock. These form the main indications of angioplasty in our country. A very small portion, around 19%, are chronic stable angina. So if you take that 19%, minus, you exclude the 68% of clinical exclusions which ischemia study had, we remain in our hands with only 6% of patients with chronic stable angina. And further, if you subject them for CT angiography or nuclear imaging, not enough ischemia, unprotected left main, etc., another 30% screen failures. So out of these 18, only 4% people satisfy the ischemia criteria. In ischemia study, around 87% patients had LAD involvement, around 50% of that was proximal LAD, 70% circumflex, 70% RCA, and the guideline-based medical therapy was extremely aggressive. Smoking cessation, more than 30 minutes of walk, blood pressure measurement less than, blood pressure control less than 130, LDL less than 70, achieving ideal BMI and maintaining HbA1c below 7 were one of the goals of the therapy. And at least 4 drug regimen, aspirin, statin, ACE and beta blocker were given to all, P2Y12 inhibitor to those who underwent intervention, and ezetimibe and evolocumab to those who could not achieve LDL despite maximally tolerated dose of statin. What does that mean? That means this was a very rigorous medical therapy. On the top of that, these medicines were provided free of cost. There was frequent consultations, pill count, adherence to medications was tested, regular blood tests to meet target levels, and at follow-up visits, consulting with a psychologist for smoking cessation, dietitian for weight control, and rehabilitation physiotherapy specialist for exercise protocols. Mind you, so this was the rigor, this was the integrity, this was the conviction, this was the attitude of the impeccable optimal medical therapy in ischemia trial. Now, may I ask you a question? How many patients in this country on medical therapy, so-called medical therapy, must be getting a rigorous or a enthusiastic, supervised, completely free medical care like this? And the answer to this question is very, very simple. Practically none. 81% were adherent to medication, 95% were on statins, 25% on ezetimibe, and all these targets, BP, LDL, triglycerides, HbA1c, smoking cessation by more than 90% were achieved rigorously in all patients. So please remember, this medical arm was one of the most tailored, guideline recommended therapy arm, supervised with attitude, conviction, and with patient education. Now look at cardiac catheterization. The conservative arm, 28% landed up in cardiac catheterization at the end of 4 years, because 14% of they had suspected or a confirmed event. These events could be easily picked up because these patients were under supervision. These patients were under continuous telephonic contact. And out of them then, in conservative arm, 23% underwent intervention or revascularization at 4 years. They were not, 16% of them were not preceded by any events. But mind you, these were religiously followed up patients. And out of those who underwent an intervention, 75% had PCI and 25% had CABG. So if we look at the primary outcome, it didn't differ significantly at 4 years. But look at this, the curves have started diverging at around 2 years. They continued to diverge. And it would be anybody's guess, if the trial would have continued up to 8 years, how much these curves would have diverged or whether they would have converged. So this was a primary outcome. Look at the cardiovascular death and MI. Again, the curves are diverged at 2 years, continued to diverge till 4 years. Not statistically significant, yes, I agree. But nobody would know if the trial would have continued for another 2 years or 3 years, what would have happened. Cardiovascular death, no significant difference. All-cause death, no significant difference. But I request, my friends, we need to look beyond. And if you look at the MI, procedural MI were a little higher in the invasive arm. In fact, much higher than that in FAME2 studies. They were FFR guided studies. This was angiographically guided PCI. The MI's rate was 2%, which is higher peri-procedural MI. But look at this, after 1 year, the spontaneous MI, the curve started diverging and invasive arm did much better. In fact, it is a spontaneous MI which decide the patient's outcome. Hospitalizations for unstable angina, again, were much, much lesser in invasive arm. One has to remember that. In our country, where people are staying in 3-tier cities, 2-tier cities, and 4-tier cities where even medical facilities may not be as good. If you look at the pre-specified important subgroups, this is very beautiful and very interesting. People who are having core lab eligibility criteria, look at them. They were benefited by invasive strategy. People are core lab ineligibility, they were benefited with conservative arm. And if you look at the subgroup analysis, patient assigned to the invasive strategy had greater improvement in angina-related health status than those assigned to the conservative strategy. And this is further analysis in patients with left ventricular dysfunction by Renato Lopez et al. And this showed that, look at these first two bars, LV between 30, below 35 were excluded, we know that. But between 35 and 45, cardiovascular death or MI and primary endpoint substantially better in the invasive arm. So people with left ventricular dysfunction behaved much better with invasive strategy. And it's the same thing showing this is conservative. These two are conservative and invasive with left ventricular preserved function, but left ventricular depressed function. The invasive arm fared much worse than the invasive arm, which is in red. So please remember the cumulative incidence curves and primary outcome according to, when you study according to LV dysfunction, the LV dysfunction arm, the invasive arm was better. So what are the strengths of ischemia trial? A rigorous design requiring presence of obstructive epicardial coronary artery disease on a CT angio. Not a single patient, the coronary anatomy was not known. This is important because prior trials have randomized patients after coronary anatomy was identified, and many patients believed to have high risk anatomy might have been excluded. The trial was not industry funded. Very few patients were lost to follow-up. Rigorous assessment of outcomes, including quality of life. Control of cardiovascular risk factors were immaculately beautiful, but there were limitations. The trial was an open design trial with no sham procedure. As you know, in Orbita trial, there was a sham procedure on patients who underwent a conservative strategy. Sham angioplasty. This was not the case here. And many patients with this kind of ACS, highly symptomatic patients, left main stenosis, LVF less than 35 were excluded. So these findings could not be generalizable to centers with high procedural complication rates, and very minority of women were included in the study. These were the limitations of this trial. So how do you take home message from this clinical practice? In stable CAD, you should have aggressive therapy with at least 4 drug therapy. It should be supervised with intense lifestyle modification. It should be target oriented. BP less than 130, HbA1c less than 7, LDL less than 70, BMI ideal. And you need to avoid reflex angiographies unless there is an event, or unless patients are non-compliant to therapy, or unless there is a failure of medical therapy. That is the message with this trial. And please remember that before we start beating our drums that medical therapy is definitely better than invasive strategy, remember, invasive strategy was a better choice if the patient remains symptomatic despite optimal medical therapy. Invasive strategy is better if safely performed with straightforward, with very low risk, in good hands with proximal lesions. Because lower MI rates, spontaneous MI rates in the long term in the invasive arms, we all have seen that. In ischemia trial, the spontaneous MIs were much lesser in invasive arm over long term. So if somebody could do a good PCI, a safe PCI, a beautiful PCI, or proximal LED lesion in an invasive arm, that could be much better. If patient is staying in remote areas, medical therapy, unsupervised medical therapy could prove dangerous. If patient is non-compliant, the medical therapy could do dangerous. And the patient has no access to immediate tertiary care facility, again, medical therapy could prove dangerous. So if the patient fails to control his angina on medical therapy, definitely invasive strategy is better. Also, if the patient is younger, more active, frequent traveler, less angina, better quality of life with invasive therapy. So please remember, don't start beating your drums saying that ischemia means medical therapy and angioplasty, or medical therapy and revascularization are equal, though they are not. So if you compare the FAME, which showed 35% reduction in FFR guided angioplasty versus angiographically guided angioplasty, and FAME2, which showed FFR guided angioplasty much better than medical therapy or angio guided angioplasty, angiographic guided angioplasty, ischemia has proven that angio guided PCI is equal to medical therapy in most of the patients. I'm saying most of the patients, but not those with recent ACS, not with recent angioplasty within last 1 year, not those with ejection fraction less than 35%, not those with medically uncontrollable angina, not those with large area of ischemia who are non-compliant to therapy, not those who don't want to follow a supervised, adequate, optimally guided, aggressive medical management. Those patients who cannot do that, for them, medical therapy is not the question. So the take-home message from the Indian concept is this study does not apply to recent unstable angina, recent MI, left main disease, severe symptomatic angina not responding to medical therapy, left ventricular dysfunction with an EF of less than 35. Also, I showed you ejection fraction between 35 and 45. Also, invasive strategy has done much better than conservative strategy. Those with previous angioplasty or bypass surgery, those without the knowledge of coronary anatomy, don't just tell them that medical therapy is good enough for you. Please remember, ischemia trial, there was not a single patient in whom coronary anatomy was not known. And those who prefer intervention, please don't deny them. So please remember, ischemia trial applies to only approximately 6% of patients in India of chronic stable angina undergo intervention annually as per our registry, as per our interventional registry. Remember that. So as the clouds become lesser and lesser, we can see the ships better and better. So we know the path better. We know the picture better. So please try to read this trial properly, dig it properly, interpret it properly. And the interpretation is this, that now this trial creates a greater responsibility and partnership between a clinical cardiologist and an invasive cardiologist. So you have to fine-tune the optimal use of this trial in those 9% patients of chronic stable angina who fit into the eligibility criteria of ischemia trial. Only 9% patients of stable coronary artery disease. In any case, I showed you, in our country, only 19% of patients of total PCI are those in stable angina. Not to overuse or oversell either medical strategy or invasive strategy because of a reluctance for another strategy. That means a clinical cardiologist should not say medical management, medical management, medical management. And invasive strategists should not say that only invasive, invasive, invasive. You should have a hard team approach. So you should have partnership in clinical cardiologists and invasive cardiologists. You have to tailor the strategy at an optimal time frame for an appropriate patient for a shared decision making between treating physician, clinical cardiologist, invasive cardiologist, and the patient and his spouse. That is the message of this trial. So I think I have done a job of telling you, dissecting you this trial, putting it wide open in perspective to suit the Indian context. Thank you very much. And thank you once again, Dr. Tom Devasiya and Dr. Sudhakar, for inviting me here. Thank you very much.
That was Dr. C.K. Ponde from Mumbai. Thank you, sir, for a wonderful dissected discussion on ischemia trial. We really appreciate your wise words. Now, coming back to the question, I would like to know your opinion whether this publication of ischemia trial, has it changed your practice at all?
Yes, I think one way it has changed, that our oculostenotic reflex, that means angiography, you see a stenosis and you feel like putting a stent in there, that reflex has completely been dwarfed and completely been killed by this trial. So we know now that if you have a patient with angina and significant coronary artery disease, maybe 70% stenosis in 2 or more arteries, but is willing to follow 4-drug regimen, a statin, an aspirin, a beta blocker, and an ACE inhibitor, plus minus a P2Y12 inhibitor, plus minus ezetimibe, to maintain rigorous goals of controlled BP, good exercise, and his angina is well controlled on medical management. That means not a single episode of angina requiring sorbitate in a week, less than 1 episode of angina in a week. This is a patient whom you can safely manage with medical therapy. Of course, the exclusion will remain. You should not have LV dysfunction. You should not have recent ACS. You should not have recent PCI or CABG within 1 year. And you should not have left main disease, significant left main disease. Excluding those patients, other patients can be managed medically. But important trial messages, you have to follow these patients telephonically, by mail contact, by physical contact, or by our healthcare nurses so very beautifully that the moment their symptoms become little worse, you have to bring them in and put them in the invasive arm. If that is what you can do, if that is what you can achieve, if that is what you can rigorously follow, then this trial is for you. That is what the message is.
Thank you very much. Also, one more final question for you. In the present world, in Indian context, do you think it is easy for us to rigorously monitor even a slight change of symptoms for these patients when they become unstable? Is it possible for our team to get in touch with them and bring them in so as to push them into the invasive arm so that their quality of life and probably mortality benefit is there?
Yes. That's very, very important. Very, very important. That the moment they have a change of their symptoms, increase in the frequency of angina, or increase in the duration of angina or severity of angina, they need to be brought in. They need to be called back to our center to study their coronary anatomy, whether any plaque has become vulnerable by OCT or any plaque has become much more worse than what it was at the time of enrollment. So that is very important. There's a question here which says that vulnerable plaque evaluation in ischemia trial. No, that was not done. The trial was not an imaging trial. The trial did not do IVUS or OCT to see the vulnerability of the plaque. The trial even didn't do FFR like FAME1 and FAME2 studies, which were guided by the FFR. In FAME1 and FAME2, as I showed you, that FFR guided angioplasty was superior to angio guided angioplasty, angiographically guided. So that's what I'm saying. Even this is what I was just on an NIC panel around an hour ago. In STEMI, to do only culprit vessel or to do all the vessels. When we do FFR, we become much wiser. Some stenosis may look very worse to your eyes and you feel like you're tempted to do them. But when you do an FFR, you find FFR is normal. So leave them alone. So I think FFR and imaging has taken coronary interventions at a completely different level altogether. But of course, this trial was mainly a clinical trial with ischemia. And as you said, sir, very correctly, the moment the symptoms change, these patients need to come in and cross over from the conservative arm to invasive arm. And that is what, if you can do, then definitely a large proportion of patients you can treat medically as long as it takes, as long as they allow you to treat you medically, and then subject them to invasive strategy. Thank you, sir. Thank you for inviting me here. It was a great, great honor, Dr. Tom. Great, great privilege. And maybe in future I'll be able to visit your institute sometime. Thank you, sir.
Please do visit us. And it was a great feeling for us to listen to you all the way from Hinduja Hospital, Mumbai, Dr. C.K. Pandit, sir. Thank you very much.
Thank you. Thank you, sir. Thank you very much, sir. Thank you.
We now move on to our next talk. Dr. Commodore D.S. Chadda will be speaking to us on management of non-culprit vessels in ST elevation MI patients. Let us listen from him.
Good evening, everyone. I must thank the organizers for giving me the opportunity of sharing my thoughts on current status of non-culprit revascularization in patients of STEMI. As you all know, revascularization is the backbone in the treatment of patients with ST elevation myocardial infarction, and primary PCI has definitely improved the outcomes. However, when we do the primary PCI, we've noticed that about 50% of these patients also have some non-culprit lesions, and these are associated with worse outcomes. As you can see on the slide, those who had the non-PERC related artery or disease, they had worse outcomes, and this is particularly true because they undergo incomplete revascularization, and this is commonly seen in elderly and diabetics, patients with heart failure, and those who have prior myocardial infarction. So the slide here shows you a very common scenario, two cases, one with anterior, one with inferior wall MI, and both of them have got non-culprit lesion, a significant LAD and RCA disease. So what should one do? So this is the question which we'll answer over the next 10 to 15 minutes. There are some risks and benefits of revascularization. Let's look at the benefits. The benefits primarily stem from the fact that you decrease the infarct size, you reduce recurrent MI by causing plaque stabilization. You also reduce the length of stay and reduce the recurrent ischemia, which all lead to improvement in the prognosis. So what are the risks? The risks are it's an unstable situation, and you might end up increasing the infarct size by causing more distal embolization. You're going to use more contrast, so it might translate into contrast-induced nephropathy. You're going to use a lot of anticoagulants, the bleeding risk increases, and you definitely add on to the cost, which is very important in the Indian setting. The other major problem is that the assessment of the lesion can be slightly difficult because in the acute MI situation, you have coronary spasm, and you will not be in a position to assess the lesion properly. And the final question which a lot of people ask is that, why do this lesion? It is not for this lesion that the patient has come onto the table. So, if we have to revascularize, how do we decide? What are the parameters which we use? Age-old coronary angiogram, we know that it's got its own limitation, but this is the one which is most commonly used. You can use coronary physiology, IFR, FFR for the assessment of lesion. and imaging. So these are the three tools which we use for deciding whether we need to intervene in the non-culprit lesion or not. Let's look at the angiographic data. This is the slide which has been taken from the PRAMI trial. There, when they revascularized lesions with 90 to 95% stenosis, they detected 20% of the event causing lesions only. However, when the threshold was changed, it was when they included 75 to 99% of stenosis, they detected almost 81% of event producing. So angiography has got its own limitations, and as I told you, there is a lot of catecholamine surge during STEMI, and the lesions can appear to be more severe than they actually are. Physiology has emerged as an alternative, and FFR, IFR, they have become a very valuable tool, and we have enough clinical data to support their usage in different clinical scenarios. Is FFR reliable? The FFR certainly is reliable, as is shown on this slide in this elegant trial. The FFR done for the non-culprit lesion in the acute stage as well as during the follow-up did not show any variation. One can reliably use a physiological tool for assessing the severity of coronary lesion. Imaging has been around, and you can pick up a lot of thin cap fibroatheromas or the unstable plaques. These are the plaques which are associated with adverse outcomes. But do we have enough data to support this? Recently in TCT Connect, we had the Prosper Absorb trial data being presented. This was a trial which used IVUS along with near-infrared spectroscopy to assess the unstable plaques. They looked at the plaque volume as well as the lipid core. And what they found in their study is that at the end of 2 years of follow-up, those plaques which had more than 70% of those lesions which had more than 70% of plaque burden, they had more number of events, both at the level of the patient as well as at the lesion. And this slide shows the near-infrared scopy data. The lipid core, the larger the lipid core, more were the events. So a lipid-enriched plaque certainly translates into more events when followed up over a period of time. Well, what is there for us from the clinical trials? This is how we select. We can use coronary angiogram, imaging, or patient symptoms. But what are the lessons which you've got from the clinical trial data so far? Well, as I told you, we have three options in patients in multivessel PCI. Either we do the revascularization immediately, or we do it in a staged manner, or we have the conservative arm where we put the patient on medical therapy, which is not the one which is followed over in majority of the patients. So if you can stratify them based on angiogram. This slide shows the angiographic stratification which was done in the PRAMI and culprit trial. These were the patients with multivessel PCI, multivessel disease at the time of initial presentation for STEMI, and they were stratified based on the angiogram. So in the PRAMI, where there were about 450 odd patients, non-culprit lesions were addressed. So about half of the patients underwent a preventive PCI, and these were noted to have lesser number of events. In the culprit, there were about 300 odd patients who underwent, of which half of the complete revascularization. These were both very small trials, and they were not powered to detect the death and MI. So, but all the same, they had a tremendous impact. And as you can see in this, the ACC/AHA guidelines for 2013 put in red the PCI for the non-culprit lesion. However, post culprit and PRAMI, these guidelines were revised, and they were changed to 2B. So now the revascularization of the non-culprit lesion had become class 2B in the revision or the focused update which came in 2015. Well, if you stratify these lesions physiologically, that means using IFR or FFR. We had two elegant trials, which were the Dynami 3 Pri-Multi and the Compare Acute. In these, both the trials, the lesions were stratified on the basis of the physiological assessment. FFR was used in both these trials, and complete revascularization was done during index PCI in Compare Acute and during index hospitalization in Dynami Pri-Multi trial. And it was noticed that both these trials, complete revascularization translated into lesser number of events, and they produce a lot of beneficial effects. So to summarize what I till now is that the initial registry data suggested that the treatment of primary PCI, the non-culprit lesion of the primary PCI, is harmful, and that is how in 2013 guidelines said that please don't touch these lesions. However, there were small and medium trials as well as meta-analysis which suggested the benefit. But this benefit was essentially based on reducing the number of revascularization and without addressing the composite hard endpoints of death and myocardial infarction. So there was a need for a larger trial which could assess, and a step in this direction was the recently published COMPLETE trial, which randomized STEMI patients into complete revascularization or culprit vessel revascularization. This trial had about 4,000 plus patients, and the complete revascularization was done either in a staged manner, in that it was done within a median period of 23 days, or was done during the index events. These patients were followed up over a period of 3 years for the composite primary endpoints, and the trial data was very, very encouraging. It showed that the complete revascularization was achieved in 90% of non-culprit lesions with a residual index score of 0. It led to reduction in the cardiovascular death and MI by 26%. And if you add to this the ischemia-directed revascularization, the benefit increased to 49%. So the message was very clear that when you revascularize the non-culprit lesion in patients with STEMI, either during the index hospitalization of the median duration of 1 day or in a staged manner, you achieve a lot of benefit, and you do not have any significant difference in the bleeding, stent thrombosis, or AK rates in these patients. Well, there's another study which came out in this year, which was published in the JAC. This was the co-op registry data, which looked at ACS patients, and they had a substantial chunk of STEMI patients in that. And this also showed that complete revascularization is the way forward, because it reduces the all-cause death, new MI, and target vessel revascularization. It also identified the subsets which derive benefit, the improved outcomes are noticed in patients who are younger than 75. Patients who are a little older have more comorbidities and hence have bad outcomes. Male patients benefited more because it was seen that the female patients have very few non-culprit lesions and they are less likely to rupture. Higher disease burden was associated with worse outcomes, and the benefits are noted in those irrespective of their diabetic status. So almost all the subsets of ACS, which includes unstable angina, non-STEMI, and STEMI, benefit from complete revascularization. There's another important subset which we commonly get to see when the patient presents to us with STEMI. These are the patients in cardiogenic shock, and this could be seen in about 30 to 40% of patients. The earlier guidelines recommended that we should revascularize the non-infarct, non-culprit lesions in these patients, but there has been a revision in this. This revision came after the culprit shock trial, in which it was noticed that complete revascularization was associated with worse outcomes. It is recommended that one should do a stage PCI for the non-culprit lesions in patients with cardiogenic shock, and this was shown to be leading to lesser number of deaths and renal replacement therapies at 30 days and 1 year. However, this does entail the risk of higher incidence of heart failures and repeat revascularizations in these patients, but one should not attempt to do a complete revascularization or address the non-culprit lesion in patients who present with cardiogenic shock. The STEMI guidelines from the European Society of Cardiology have been accordingly modified, and in 2018 STEMI guidelines have made NCL revascularization class 3. To summarize, what I have mentioned is that it is prudent to revascularize the non-culprit lesions, but there are certain factors which have to be kept in mind. Patient stability is most important. As I told you, patients with cardiogenic shock don't do very well. You need to accurately localize the lesion and identify the culprit of the non-culprit vessel. This is particularly important when you don't see a thrombus-laden lesion, and more importantly in patients who have got multivessel disease. You can have these patients with complex morphologies, with almost 20% coming with calcification, 15% coming with CTOs. So you really need to assess the significance and address the lesions accordingly. Patients with anterior wall MI draw more benefit out of non-culprit vessel revascularization. The success of the given procedure, depending on its complexity, has to be kept in mind. And as I told you, one should not go ahead and attempt chronic total occlusion at this stage, because it is best left to be done in a staged manner. Above all, there are certain risks of intervention. You can cause contrast-induced nephropathy, more so in the elderly patient, diabetics, and in patients who have come in cardiogenic shock. So one has to, take a very balanced call, and one should thereafter attempt to revascularize these patients as soon as possible, and preferably within the first 45 days. So what will be my approach to patients with STEMI? Well, if I have an acute STEMI with multivessel disease, I would, if there is no multivessel disease, I will just do the primary culprit vessel lesion and the matter is over. If there is multivessel disease, then I would address the significant non-culprit lesion if the patient has ongoing ischemia or the lesion shows thrombus, ulceration, or plaque rupture. But the caution here is that I will withhold the PCI if there is chances of patient developing contrast-induced nephropathy, he has intolerance to DAPT, or there is TIMI2 flow in the culprit vessel. Even those patients who have very high syntax scores will also be staged. In a stable patient, you can always hold off and do the non-culprit lesion within the first 45 days. Whereas some of these patients might need a referral for CABG. These are especially those patients who have multiple CTOs or have very high syntax scores. So one should keep all the options open. To conclude, I would say that immediate and staged complete revascularization within 45 days of the non-culprit lesion in patients with STEMI is associated with good clinical outcomes. However, this has to be attempted judiciously. It should not be that you know that addressing the non-culprit lesion is going to translate into benefits. You go ahead and do all of them all at the same stage and subject the patient to adverse outcomes. We need further long-term follow-up to define the outcomes better. Till then, I very strongly advocate that the non-culprit lesions post-assessment, either angiographically or using the physiological tools, needs to be addressed within 45 days period of the index event. Thank you.
That was Air Commodore Devinder Singh Chadha. Thank you very much, sir, for your detailed evaluation of a patient with multivessel disease while undertaking ST elevation MI primary PCI. I would like to ask you one real world scenario. Let us say you do a primary PCI for a patient today, and tomorrow you are evaluating him. Next day morning, what are the factors you would consider before deciding this patient should have residual revascularization within this discharge versus this patient should wait 4 weeks before residual revascularization?
Yeah, thank you, Tom. Thank you for having me here in the first place, and that's a very nice real-world question which you've asked me. So the important factors we take into consideration are, apart from the clinical inputs, which probably include his diabetic status, age, renal function, because these are very important. You know, you have to have a composite assessment and not merely look at the angiogram and decide. But if you restrict yourself only to the angiogram, I would look for the territory involved. You know, if I look at the vessel which predisposes into a larger risk, that means a vessel which is supplying a larger chunk of myocardium, say if it's a left main lesion or a proximal LAD lesion, my threshold of intervention is going to be much lower. I would like to address it in the index hospital admission itself. And if I have the access to tools which will help me take my decision, I would certainly exercise that and use physiological tools. As I mentioned, that if I have access to FFR and IFR, I would certainly take the patient back onto the table and next day and assess the culprit lesion. If he was unstable at the time of the primary event, I would certainly do it within 48 to 72 hours. So what is more important is that I have always been saying this, and I always maintain in different platforms, I have kind of allergy to contrast. I always say this because the more contrast you give, the worst outcomes you achieve. And we have this bad habit, and I've gone through this phase, and that's why I'm saying we, because I would check my angiograms in different views and appreciate, okay, this vessel was blocked, how nice it looks in caudal, cranial, and then you shift the patient to the ward, and you get called that patient either is in pulmonary edema, and if you really buggered him nicely, then probably you have to help the CPR team. So that's why I say finish the job as quickly as possible with minimal contrast, and then put all the clinical as well as angiographic parameters on the table, and then decide whether he can come back or you need to wait for some time.
Thank you very much for the answer. Dr. Sudhakar, would you like to clarify some doubts?
Thank you, sir, for such a awesome presentation. I have one question, sir. Like, based on the available data, is there a difference between doing the non-culprit on the same admission on another day versus within 45 days?
So, the data which is available now with us, the most robust data comes from the complete trial. In complete trial, they had fact number one was that if you address the non-culprit vessel or if you do complete revascularization, you have much better outcomes on follow-up, and this is what they noticed at the end of 3-year period. Now, the next important question you asked, which is to be answered, is whether I do it while I'm doing the culprit vessel, whether I address the non-culprit vessel and the culprit vessel together, or can I stage it? So what they found out in the trial was that even if you stage the non-culprit vessel, the median period of staged PCI in complete trial was 23 days. So that means you have a window of 3 weeks to get the patient back. And what they suggested, because the largest period which they had was about 45 days. So they said within 45 days, you can get the patient back onto the table. So you have a 6 weeks window to get the patient back onto the table to address the non-culprit lesion.
Yes, thank you so much, sir.
That was Air Commodore D.S. Chandra. Thank you, sir, for your wonderful detailing. Have a nice evening. Let us move to our next speaker.
Thank you.
Dr. P.K. Sahu from Bhubaneswar. He will be discussing with us on Rivoraxaban. We all have been using it for venous thromboembolism and stroke protection. But what are the newer indications? Let us hear it from Dr. P.K. Sahu from Bhubaneswar.
I thank the MANIPAL team for inviting me to a talk on Rivoraxaban, looking beyond stroke and DVT prevention in their annual update of 2020. It is a great endeavor, in fact, and I feel honored to be a participant speaker in this session. So let us see what was Rivoraxaban. If you see the timeline of development of anticoagulants, you will see that you'll see that all the anticoagulants have been started since 1940, and as the anticoagulants are being used, so we see that it was in 2008 that dabigatran and Rivoraxaban came into being. So from 1940 onwards to 2020, we have been having a host of anticoagulants which are coming into play. Now, what is the role of Rivoraxaban? If you see, we all know that Rivoraxaban has got a good role in preventing strokes, in preventing peripheral artery disease, and also pulmonary embolism, and we have used it a lot. As we cross to 2020, and we have more data on Rivoraxaban, we are sure that it has got a major role to play in coronary artery disease, whether it is acute coronary syndrome or chronic coronary syndrome, and of course peripheral artery disease. So they are the newer vistas where Rivoraxaban has a role to play beyond DVT and stroke. Now, why is it that anticoagulation is required in atrial thrombosis? Patients continue to be underprotected despite being on intensified antiplatelet regimens. As I see that in spite of giving good antiplatelets, they still remain underprotected. There's a high and increasing medical need in CAD and PAD patients, so the role of anticoagulation is necessary. There's urgent need to establish new or add-on treatments in high-risk groups. This is very important. Now let us see what exactly happens in all these patients. Or whenever there is a thrombus, it is a composition of fibrin or fibrinogen with or without platelets. It may be a platelets with fibrinogen or fibrin itself with the red. So here for the platelets we give the antiplatelets, but for the fibrin or the fibrinogen we have to start thinking of giving, that is, anticoagulants. Now this is what we call as targeting the dual pathway inhibition. We usually think of giving antiplatelet. That is one way we try to inhibit aggregated active platelets, and then we have to start thinking of giving anticoagulants so that we start taking care of the fibrin and in the long run take care of the clot that takes place. Now, if you go further, we see, if you have to see beyond stroke and DVT, as I had already mentioned, that is a potential use in coronary artery disease, in acute coronary syndromes and chronic syndromes, in peripheral artery disease, post-angioplasty, and polyvascular disease. There's the 4 indications which have come up in 2020 where we have a role of using Rivoraxaban. If you try to see the spectrum of trials that have gone in 2009 to 2019, we'll see there were 3 trials, the Atlas STEMI 46, ACS STEMI 46, and the Atlas ACS STEMI 51, which included 15,000 patients, and the Gemini ACS. These are the 3 trials that were done in ACS cases. Then in chronic patients, the Compass trial was done in chronic coronary artery disease and peripheral artery disease, and the Voyager trial was done in acute peripheral artery disease. Of course, there's another trial of the Commander heart failure which was done in heart failure patients. Now if we see, first let us come to acute coronary syndrome when the patient presents with acute symptoms, and is there a role of Rivoraxaban? Let us try to see. Now if you see, these post-ACS patients, in spite of the guideline recommended therapy, there is almost a 15% cardiovascular death, MI, stroke as the patient passes through almost 3 years. So how do you prevent this 15% incidence of events that do occur? Now if you try to see, if Rivoraxaban, the Atlas ACS TB 51 trial in which Rivoraxaban was given a vascular dose, you have seen there was a decrease in cardiovascular death, there is a decrease in both CV death, MI, stroke, and decrease in all-cause death. So this was very important, that adding a vascular dose of Rivoraxaban does do a lot of benefit in these patients. Now, Rivoraxaban reduced the major adverse cardiac events, as you see, that compared to placebo. But of course, one has to agree that there was some increase in the amount of bleeding that occurred, both intracranial hemorrhage, but fatal bleeding was not very significant. So at the cost of decreasing the reduced major adverse cardiac events, the bleedings were higher. So is there a role of Rivoraxaban in ACS? Yes, we know that DAPT is the recommended guidelines, and Rivoraxaban vascular dose plus DAPT is an alternative, and there has been seen a significant reduction in cardiovascular death and all-cause mortality in secondary prevention of ACS in acute phase. And the most important thing is that we have to select the right patient. And who is the right patient? Those with increased ischemic risk, who have elevated tapers, those without increased bleeding risk. This is very important. With those who are at high bleeding risk, we cannot give them because they have more chances of bleeding, and use it caution, especially the creatinine clearance is less than 30. Now, to bring a balance, what you see in the green is what is a patient without bleeding risk, that is, they have no history of stroke or TIA, no current or recurrent condition of major bleed, BMI 30, creatinine clearance and hemoglobin 12.5. These are the patients which can be weighed and individually analyzed, and then you can see whether they can be put on Rivoraxaban 2.5 milligram. Now let's come to the second indication of chronic coronary syndromes and peripheral artery disease. These are the second 2 indications that we used. And then came the Compass trial, which was published on October 5th, 2017 in the New GM. Very important to note that the investigations were stopped 1 year ahead of expectations in February 2017 due to the overwhelming efficacy of Rivoraxaban 2.5 million BD with aspirin. So here is evidence that if you give Rivoraxaban 2.5 million BD with aspirin, the results are good. 3 arms are taken, one with Rivoraxaban with aspirin, Rivoraxaban, plain Rivoraxaban, and aspirin alone. And what was seen was that the patients that were selected were very high-risk patients. They all had previous MI, multiple vessel disease, multi-vessel PCI undergone, multi-vessel CABG, and most importantly, they had multiple vascular risk factors that was included as the CAD patients. And all the PAD patients had previous revascularization, previous limb or foot amputation, or the ankle index was less than 0.9, that signaled peripheral artery disease, previous carotid revascularization, or coronary disease with a low ABI. This was the criteria that was chosen, and what was seen as most interesting was whenever Rivoraxaban was added, the 2 arms definitely did better. Now, I see the vascular dose of Rivoraxaban when added to aspirin, it not only decreased the major adverse cardiac events, it decreased the cardiovascular death, MI, stroke, and of course all-cause mortality. So here is the reason, as per the COMPASS study, that we have every reason to add a vascular dose of Rivoraxaban to a single antiplatelet. Now, most importantly, it was seen that when you see the major events, major adverse cardiac events, it was significantly decreased whether the patient was a diabetic or was not a diabetic. So irrespective of the risk factor of diabetes in present, if you add this vascular dose, it was beneficial, but at the cost of the fact that there was some amount of major bleeding that was seen. Now, if we try to see the efficacy, the major bleeding at the end of 2 years were almost comparable. If you see the forest diagram over here, it does not cross to this side. It favors almost, it has got a neutral value. So it is safe to add Rivoraxaban, a very low dose, 2.5 milligram twice daily, to aspirin in patients of chronic coronary syndrome and peripheral artery disease. Now, even if there was heart failure, it was seen if no heart failure is there, there was a risk in reduction, and if the patient had heart failure, it was seen that compared to plain aspirin, if you add Rivoraxaban, there was definitely the cumulative hazard was much less. So heart failure patients also do improve to some extent, but there have been trials which have shown that in the long run it is not much beneficial. Now, a very important thing to debate on is that the absolute benefit of Rivoraxaban vascular dose plus aspirin is highest in the high-risk patient groups. So more high-risk the patient is, that is for the full COMPASS population, or more than 2 vascular beds, or history of heart failure, or eGFR less than 60, or history of diabetes, all these patients did well. And if on top of lipid lowering, blood pressure lowering, AC inhibitor, you add the vascular dose of Rivoraxaban with aspirin, it was seen that almost a 23% decrease in all-cause death and 26% decrease in major adverse cardiac events was there. So this translates to the fact that there was a 44% relative risk reduction in any type of stroke. Now, if so, the question comes that should do pathway inhibition replace APT to prevent MACE and chronic CD? The evidence that we have from comparing all these trials is that the COMPASS definitely decreased MACE much better than Capri, Charisma, Pegasus, or whether 90 or 60 with aspirin, cardiovascular death, stroke, MI, and with a bleeding risk which is much lesser than the Pegasus study compared to what the COMPASS showed. So we have reasons over here that a dual platelet inhibition is necessary in these patients. Now, COMPASS is the only antithrombotic regimen significant in all possibility. Let's see about the peripheral artery disease. It in fact decreased stroke significantly, and also the major adverse, that is the limb events, were also decreased significantly when Rivoraxaban 2.5 was added to aspirin 100 milligram BD. So if you try to summarize, whatever the substance, this diabetes, sedentary impairment, heart failure, polyvascular component, they all did well when vascular dose of Rivoraxaban was added to aspirin. So what are the clinicians COMPASS? If it is prudent to add a dual pathway mechanism inhibition, bleeding risks were almost similar, excepting for a little higher risk in the Rivoraxaban arm, and showed that it was superior to aspirin alone, and the net clinical benefit was also definitely better as seen in the sub-analysis. Now, then came the guidelines, European guidelines, where it was clearly gave a 2A indication that adding a second antithrombotic drug to aspirin for long-term secondary prevention should be patients with high risk of ischemic events without high risk bleed. Very important, any high risk patient should be put on a second antithrombotic drug, and that should be Rivoraxaban. And if you try to see the Atlas and the Compass, you try to compare them, it is seen that cardiovascular death and all-cause death was definitely reduced in the arms on whom Rivoraxaban was put. So it shows that whether it is an acute event or a chronic event, definitely Rivoraxaban does well. Now, to be summarized, we can say that it is prudent that in addition to DPT on should Rivoraxaban and gradually change over to a single antiplatelet, and even if the patient has multivessel disease, Rivoraxaban addition in chronic coronary syndromes is prudent. Now, after this, let us come to the Voyager pad, which is an acute peripheral artery disease where it was used. There are two arms, the Rivoraxaban with the aspirin arm versus the aspirin arm, and there were 6,564 patients. And it was very important to note that the Compass patients had less risk factors so far as PAD was concerned compared to the Voyager arm. The Voyager arm were all symptomatic, all undergoing revascularization, had carotid vascular disease without PAD, had 100% revascularization, or were allowed for up to 6 months of clopidogrel, and the major adverse cardiac events and acute limb ischemia or major amputations were all considered. These were a much higher risk population than the Compass arm. And then based on the Voyager, it was the 2019 European Society Vascular Medicine Guidelines had clearly gave a 2A indication that the combined therapy of aspirin with Rivoraxaban should be considered PAD patients without a high risk of bleeding or other contraindications. Even the 2019, the Global Vascular Guidelines for Management of CLTI also considered this to be a class 2 indication. Now let us take the third subset of post-PCI. Post-PCI, we can have two subsets, either atrial fibrillation post-PCI or just plain post-PCI. The atrial fibrillation post-PCI was evaluated in the Pioneer AF PCI study, in which there are three arms. After PCI, the patients who had AF, there is quite a substantial number of patients who have AF post-PCI or have AF, and we do a PCI in them, and it was seen Rivoraxaban arm versus the DAPT arm versus the vitamin K arm, and all these patients had paroxysmal persistent permanent non-valvular AF and have undergone PCI with a stent placement, and the INR was less than 2.5 at randomization. So what was seen was that when in both the arms, whether they were put on only Rivoraxaban with single antiplatelets or Rivoraxaban with a DAPT versus vitamin K antigen plus DAPT, they did well compared to a DAPT alone. So here comes the information that adding these strategies of Rivoraxaban does do well, but it is important to know that the efficacy was almost similar whether you give a VKA or a DAPT with Rivoraxaban. But we have to be clear about what is the role post-PCI, that is after PCI. Is there a role? Let's compare DAPT versus Pegasus versus Compass. If you take all the three studies, DAPT had clopidogrel or prasugrel plus aspirin, Pegasus had ticagrelor with aspirin, Compass had Rivoraxaban with aspirin. And I here show that that is the ACA, which was the adverse cardiac events, was much less in the Compass arm compared to the other arms. So this shows that possibly we have a favorable benefit ratio, risk ratio, when you add Rivoraxaban. Now let us compare to Themis, which came later on. It has shown, if you see the both compared Compass PCI with Themis PCI, it is clear that in Compass PCI, the use of a dual pathway inhibition compared with aspirin alone consistently showed a reduction in all-cause death and severe mortality, of course, with a little risk, high risk of bleeding. So We lastly come to polyvascular disease. We know that the CARISMA study has shown that if we add a dual platelet or a split, it definitely has a significant role, and there's a modest space benefit without significant reduction in mortality, MI, and ischemic stroke. But if it is continued to more than 30 months also, we see there is no significant reduction in cardiovascular deaths or stroke on prolongation of DPT for 30 months. But what happens if you add Rivoraxaban? If you add Rivoraxaban, it was seen that if Rivoraxaban was added to aspirin or alone, there was almost a 49% reduction in the ischemic and the uncertain stroke, which was very significant. Similarly, ischemic stroke was very statistically very significantly decreased. So here we have another post PCI. If you want to decrease the amount of strokes also, there is possibly a role of just giving Rivoraxaban with aspirin. And now here you see that the compass carotid clearly showed that the numbers which were much lower in the Rivoraxaban arm compared to aspirin arm. So this comes to, that is the fact that we have to look beyond stroke and DVT prevention while using Rivoraxaban. There is a role to use in acute coronary syndrome, chronic coronary syndrome, peripheral artery disease, post PCI, whether the patient has atrial fibrillation or does not have atrial fibrillation, and polyvascular disease where you want to decrease the incidence of CVS. But it is, in practice, it has not yet picked up this much, but we had much evidence. And there are two studies which are like, the Rivoraxaban did not show superiority. One was the Commander heart failure study, because we are discussing over the recent advances. The Commander heart failure study did not show a good benefit of Rivoraxaban in this subset of patients. And Rivoraxaban was also used post-TAVI patients and was shown to have, the Rivoraxaban had a higher rate of major disabling or life-threatening bleeding versus the antiplatelet group. So it is not recommended. So it's not recommended that your patients who undergo TAVI should be put on Rivoraxaban in contrast to antiplatelet. So lastly, to conclude, Rivoraxaban possibly is jumping from use in stroke, DVT, pulmonary embolism to newer vistas of CAD for ACS and CCS, PAD, post-PCI, polyvascular disease, and possibly this newer thing, that is this NOAC, to see that we have a larger spectrum to use and give more benefit to our patients. Thank you very much for the patient hearing.
That was Dr. P.K. Sahu from Bhubaneswar. Thank you, sir, very much for your wonderful talk. I would like to ask you one question. What do you think? Is it exclusive for Rivoraxaban to have these additional vascular benefit both for coronary and peripheral, or do you think these benefits may be extended to other newer oral anticoagulants as well?
See, whatever this thing, that is data we have as of now, even apixaban was used, but it was never found to be as effective as Rivoraxaban. Excepting for the fact that Rivoraxaban is a NOAC which is contraindicated in patients who have a low EGFR. That is most important. But whatever data we have as of today, Rivoraxaban has proved to be useful in ACS situations, CCS, PAD, and also post-PCI patients. But frankly speaking, our DAPT molecules are so potent. So maybe now we are trying to switch from DAP to SAPT. So is there really a need of adding this thing that is a NOAC? That is a big question. And most of us as clinicians hardly do add this. But definitely, because we have data, what we can say is that for our high-risk patient, there is a scope of adding, doing a dual pathway inhibition and giving a NOAC in addition to a single antiplatelet. And the choice of the NOAC is always Rivoraxaban.
Also, one last question. What would be the single most important limiting factor in the use of Rivoraxaban for these indications which you discussed on a large scale? Is it the price or is it something else?
In fact, it is bleeding, which we have seen, whatever studies have been done, there has been higher chances of bleeding when you add Rivoraxaban. Although the major adverse cardiac events are much lesser, the events were much lesser, even the limb ischemia and the amputations are much lesser, but definitely bleeding is something which we have to be very careful about.
Thank you very much for the wonderful answers. We thank from MANIPAL Cardiology Update for your participation. We move forward for the next talk from Dr. John Jose from CMC Vellore. Transcatheter aortic valve replacement. Are we ready for the low-risk patients? Let us hear it from Dr. John Jose.
Dear colleagues, it's great to be part of this update program, and I'd like to thank Dr. Tom for this opportunity. My talk is on TAVI in low-risk subjects. Over the past decade, TAVI has evolved to become the treatment of choice for severe symptomatic aortic stenosis in the elderly. TAVI procedures outnumber SAVR cases in most Western registries. The risk classification of severe aortic stenosis is based on surgical risk scores. The most commonly used are the STS and Euro scores. Low risk is generally defined by an STS or Euro score less than 4. The largest population suffering from symptomatic aortic stenosis are actually low-risk patients. So recently there has been an increasing trend to offer TAVI to low-risk subjects. This trend derives from the non-inferior results of TAVI observed in recent large and well-designed intermediate risk trials. In the partner trial, TAVI was associated with lower deaths, lower strokes, lower major vascular complications, less atrial fibrillation, and early recovery with a median duration of hospital stay of about 3 days. In the intermediate risk TAVI trial, TAVI was found to be non-inferior to surgery. So in summary, RCT showed that TAVI is associated with lower strokes, lower deaths, less atrial fibrillation, faster recovery, better hemodynamics. TAVI is also less invasive and better tolerated in cases of instability. So these differences allow for TAVI to expand its role beyond the traditional ones. So what do the guidelines say? For high and prohibited risk, TAVI has a class 1 indication. For intermediate risk, it's a class 2 recommendation. So let's take a look at some of the low-risk trials. So what is the definition for low-risk in trials? For most trials, it is an STS score less than 4. For the Evolute low-risk trial, it was a predicted risk of mortality less than 3 at 30 days as per heart team assessment. One of the earliest data on low-risk patients came from the Notion trial. Notion trial was a randomized non-inferiority trial comparing TAVI and SAVR in 280 patients. 80% had an STS score less than 4 with a mean age of 79 years. There were no significant difference between TAVI and SAVR at 1 year, but the pacemaker rates and the rates of moderate aortic regurgitation was significantly higher in the TAVI group. In the German Gary register of about 20,000 low-risk patients, the hospital and 30-day survival was higher for TAVI patients. Recently, the results of the Partner 3 and Evolute low-risk trials were published. Both were multicentric RCTs comparing transfemoral TAVI with last generation device in SAVR. The primary endpoints differed across both trials. For Partner 3, the primary endpoint was a composite of death from any cause, all stroke, or rehospitalization due to valve or procedure-related causes at 12 months. In comparison, the primary endpoint in the low-risk Evolute trial was all-cause mortality and disabling strokes at 24 months. So these are the salient baseline characteristics of both the studies. The mean STS score was 1.9. The mean age was similar at 73 and 74 years. The primary composite endpoint was lower for TAVI in both the studies. TAVI was associated with a significant lower rates of atrial fibrillation, but the rates of pacemaker was found to be higher for TAVI in the Evolute trial. In the Partner 3 trial, all-cause deaths were numerically lower for TAVI. They also had lower rates of stroke and rehospitalization. Major bleeding and acute kidney injury were also lower for SAPIEN 3 TAVI group, but the rates of new onset left bundle branch block was significantly high. There were no difference in other endpoints such as coronary obstruction, endocarditis, reintervention, or valve thrombosis. There were no significant differences with regard to paravalvular regurgitation or effective orifice area. As I mentioned earlier, in the Evolute low-risk trial, TAVI was found to be non-inferior to SAVR for the primary endpoint. CoreValve achieved a numerically higher aortic valve orifice area. TAVR group had low risk of disabling stroke, bleeding complications, acute kidney injury, and atrial fibrillation. A recent meta-analysis of all RCTs on TAVI across the entire risk spectrum showed a reduction in mortality and stroke rates. So can we offer TAVI to all aortic stenosis patients? There are issues that need to be settled before TAVI can be offered to all patients. Concerns are, is evidence strong enough? What about the durability in a younger population? What about valve thrombosis? Is TAVI cost effective in younger population? What about anatomical and operator experience? What about asymptomatic patients? So let's take a closer look at the low-risk trials. Partner 3 had an unblinded adjudication of endpoints. This could have led to some bias in outcome assessment. The trial included a highly selected population. It excluded patients with bicuspid aortic valves and poor transfemoral access. The follow-up period was limited to 1 year. Addition of rehospitalization to the composite endpoint made it a weak endpoint. High incidence of rehospitalization after SAVR is well acknowledged, and this was the main reason for superiority of TAVI over SAVR in the first year of the trial. The EVOLUTE trial failed to emphasize that only 10% of patients actually reached a 2-year follow-up. They had imputed data from patients with less than 2 years and combined with those over 2 years using an OL-based analysis. So who were the study participants? They were patients at low surgical risk with ST score less than 4. We know that current risk scores have limitations. They were developed for surgical populations. They do not account for rare conditions. Many variables are not captured, for example, frailty. Definition of risk factors lack precision. They do not account for operated or hospital experience. So were they really low-risk patients? Patients selected were actually at low risk for suboptimal outcomes after TAVI. They were suitable candidates for the transfemoral route. They had high coronary takeoff. They were tricuspid valves. There were no severe aortic annulus or alveolar calcification, which means they were highly selected patients, and they may not be representative of the low-risk real-world population. So what about the age? The mean age was a half a decade lower. Lower risk does not imply lower age. So what about durability and structural degeneration? The data for durability are not strong enough because most studies are around for 6 to 8 years only. The rates of structural degeneration seem to be similar for SAVR and TAVI valves at 6 years, being about 7%. We know that pericardial valves start to fail after 7 to 10 years. At 10 years, the freedom from structural degeneration is about 72%, and it drops down to less than 50% at 12 years for surgical valves. So this is a graph showing average survival for an individual born in the US. It may be lower for us, but we could make a little bit of extrapolation. For someone at 60 years, the life expectancy is about 20 years. So let's take an example of a 63-year-old with severe aortic stenosis. He gets a TAVI at 63 years. 9 years later, his valve fails. He requires a valve-in-valve procedure. When the first valve is supraannular, then there is a risk of coronary obstruction. Treated TAVI will result in increased gradients and give suboptimal results. 5 years later, at 78 years, he experienced valve degeneration. He has developed additional comorbidities. He is now at high risk. Surgeon is not happy to operate. What do we do? So unless there is a long-term data of more than 10 years, there will always be concerns on durability. TAVI, especially self-expanding valves, are at high risk of permanent pacemaker, which brings in added cost and morbidity, including risk of lead infection, endocarditis, and left ventricular dysynchrony. Bicuspid valves were largely excluded from large randomized trials of TAVI. Challenges for TAVI in bicuspid valves include heavy eccentric calcification, elliptic aortic annulus, abnormal coronary takeoff, and horizontal aorta. They're also at high risk of annulus rupture and aortic dissection. TAVI with early generation devices were associated with more frequent aortic injury, higher rates of AR, vascular complications, more frequent conversion to surgery, and significantly lower device success. There were no differences for AR with newer devices, but procedure success rates were low and pacemaker rates remained high. Finally, the issue of valve thrombosis. The incidence of subclinical leaf thrombosis is as high as 40% with some valves. For some patients, it has been associated with neurological events. So in conclusion, are we ready or are we too early for TAVI for low-risk patients? There are major hurdles to widespread diffusion of TAVI in low-risk patients. The challenges are unknown valve durability in a younger patient population with higher prevalence of bicuspid valves that were not included in trials, higher rate of vascular complication, leaflet thrombosis, permanent pacemaker, and AR rates compared with SAVR. So therefore, I feel that we should not be too opportunistic about the low-risk trial evidence. Short-term data from trials may not be sufficient to support TAVI in patients with longer life expectancy. Without data on long-term results of TAVI in younger patients, it's perhaps too early to offer them TAVI. Heart teams are even more important now in order to make the best decision for an individual patient. So TAVI for low-risk patient is actually about learning who not to treat. Thank you.
That was Dr. John Jose from CMC Vellore, well spoken on TAVI in low-risk patients. Dr. John, I would like to ask you, let us say a 70-year-old gentleman comes to you and he is otherwise considered low risk. Now, when do you decide whether he is a good candidate for TAVI or you would send him for surgery? One or two important deciding factors when you see a patient as a real-world clinical scenario.
Thank you, Tom. Thank you, Tom, once again for this opportunity. So, coming to your question, so somebody who comes with age more than 70 years with aortic stenosis, low risk. So the thing you have to consider in mind are, suppose if the patient has got additional problems like additional valve disease, they got concomitant severe coronary artery disease, then he may be a better candidate for surgery. But if it's an isolated severe aortic stenosis, 70 years, then you look at life expectancy. If the life expectancy is, say, let's say about 5 years or low for whatever reason, then you might want to consider him TAVI procedure. But if he's got a good life expectancy, is a real low-risk patient, then he may be actually a surgical candidate. Having said that, we find that in our country, nowadays there is an increasing trend to do TAVI at lower age groups. We find TAVI being done in patients about 55 or 60 years. I feel that this may not be a great trend.
Thank you very much. One more last question. Does the choice of valve affect your decision in patients when you decide to do TAVI, maybe for a 70-year-old gentleman?
Yes. So there are two types of valves. Basically, balloon expandable and self-expanding valve. Most self-expanding valves are supraannular configuration. So if you're doing a TAVI in a younger patient, it's probably better to do a valve with an intraannular leaflet configuration. This is because I said this also in the presentation. If you're doing TAVI in a younger population and if you're going to put in a supraannular valve, there is a tendency that when you do a valve-in-valve TAVI subsequently, you will end up with coronary obstruction. You might be ending up doing complex procedures like basilica, etc. So if you're doing TAVI for a younger patient, always choose an intraannular valve.
Thank you very much, Dr. John, for the question. Let us move to the next topic. Dr. Sridhar Kasturi from Hyderabad. Left main disease versus CABG versus PCI, which has been a topic of discussion, hot topic for cardiologists and surgeons world over. Let us hear it from Dr. Sridhar Kasturi from Hyderabad.
Good evening to all of you. I'm Dr. Sridhar Kasturi. Before starting presentation, let me thank Dr. Tom Devesya, Dr. Sudhakar Rao for inviting me to MANIPAL Cardiology E-Update 2020. So whenever the left main is involved, it is associated with very high morbidity and mortality due to its major area of myocardial supply. It supplies almost 75% of the left ventricle. So any insult to the left main can lead to severe LV dysfunction, sudden cardiac arrest, or arrhythmias. The incidence of left main disease is observed in 4 to 6% of patients who are undergoing routine angiography. And left main disease is associated with 20% mortality rate at the end of 1 year. Medical treatment versus bypass surgery significantly improves the survival rate. That is 16% in the mortality rate is 16% in surgically treated versus 36.5% in medically treated patients. Studies related to the PCI versus bypass surgery, and that is using first generation DES. There are Lehman study, syntax left main study, Portrait study, and pre-combat study. And these are all with a limited number of patients. Mainly Lehman's only 52, they compared 52 patients with 53 patients. Relatively more number in syntax, that is 357 patients in PCI group, 348 in bypass group, and pre-combat, that is 300 to 300 patients. Now we have a data. I'll highlight mainly Excel, Google, and some of the recently published studies. And syntax is a very landmark trial that is to decide whether patient requires PCI or bypass surgery, which one is superior for left main disease. So if you see syntax, they tried with Taxus stent, that is paclitaxel quota stent PCI versus bypass group. And In this one, the 30-day mortality relatively high in bypass group compared to PCI. If you see here, the mortality is high during first 30 days. That stroke is also more in bypass group. Myocardial infarction and overall MACE rate is much lower in bypass group. That is mainly because of the target vessel revascularization. Same figures reflected even at the end of 1 year. So PCA was inferior to bypass group, particularly in terms of MACE rate. 5-year analysis shows when the syntax score is less than 32. So bypass versus Bataxis, when they compared, both groups fared equal. And if you see the cumulative event rate, 32.1% versus 31%. Whereas when the syntax score is more than 33, cumulative rate is much higher in a PCA group compared to bypass group. So if the syntax score is high, definitely surgery scores better, whereas if it is a syntax score is less than 32, mainly if it is less than 22, it's almost equivalent to bypass surgery. The Excel study here in PCI arm, they used Zyme stent. With Zyme stent, they compared with the bypass, and here number of patients are 948 in Zyme group and bypass group 957 patients. If you see the 5-year event rate, see primary endpoint, that is all-cause death, stroke, myocardial infarction at 5 years, 22% versus 19.2. Slightly favored bypass group, that is only 3%. And all-cause death, stroke, and myocardial infarction, if you see the first 1 month, PCA scores over bypass surgery, and first 1 year, 1 month to 12 months, both are equal. But after 12 months, definitely surgery is the favored because that event rate is mainly because of the target lesion revascularization. But in terms of quality of life, anginal frequency, at the end of 5 years, both groups performed equally well. This is a noble data, the 5-year start, all-cause mortality almost similar, that is 11.6 point versus 9.5. And target vessel revascularization definitely more in PCI arm compared to bypass. Stroke rate is also higher in PCI group compared to bypass group. Overall, the noble at the end of 5 years, it showed the PCI did not meet non-inferiority for the primary endpoint of 5 year compared to bypass surgery. CABG was superior to PCA, and mainly PCA resulted in higher rates of non-procedural myocardial infarction, higher rate of repeat revascularization, and all-cause mortality was similar in both groups. And this is a meta-analysis. 4,478 patients constituted left main disease. So if you see the all-cause mortality, similar in both the bypass group as well as the PCA group, that is a 5-year mortality rate similar in both groups. So if you analyze syntax 5, that is a death rate is same, almost 14.6 to 12.8, and the Excel also 13.3% slightly more, but noble similar 9.4% to 8.7%. Pre-combat also similar mortality rate. But if you see the all-cause mortality in this meta-analysis, when syntax score is less than 22, definitely it's matching with the surgical results. Syntax 22 to 32 also almost matching with the surgical results. Whereas syntax more than 33, definitely the event rate is more compared to bypass surgery group. So this is a 4Y left main PCI registry where they analyzed LMPCA patients. And these patients PCAs were performed between 2004 to 2017, and they concluded unprotected left main PCA in selected patients had acceptable 10-year safety and efficacy outcomes, though they used first generation DES. Treatment of lower risk patients stratified with syntax score. Always you assess the syntax score 2, and use the IVAS, and always try to use the best possible available tests to reduce the 10-year mortality rate. The independent predictors, they found age, lower ejection fraction, incomplete revascularization. And syntax left main, this is a 10-year data is available. The mortality in bypass and surgical group in both groups similar, like 26.7% in bypass group versus 26.1 in PCI group. That syntax 10-year data supported that no survivable difference between bypass surgery and PCI at 10 years, and significantly higher mortality with PCI and triple vessel disease, comparable survival with the CABG versus PCI and left main disease. There is one study, and this is an observational study, and those centers with high value and operators with high value, they produced the best results. So to provide the best results, so you should have a very good experience, the low value operator and high value operators. The death rate, cardiac death, and myocardial infarction, TBR, and event rate is much lower when patients are undergoing with high volume operators compared to low value operators. And this HFrecEF published this one. IVAS guided PCI, when left main PCI was performed with IVAS, the mortality is observed in angio guided 13.6, whereas when IVAS guided, it's a 6%. There was 50% reduction in the mortality rate, and the effectiveness of IVAS is very useful in complex lesions, particularly left main bifurcation and triple valve disease. So the more complex the disease, the usefulness of IVAS in reducing the event rate is very high. That is identifying the death predictors, the death predictors of outcome, and rectifying them definitely improve the long-term outcome. And how to go ahead. So how to choose whether patient, whether you have to choose PCI or bypass to a particular patient. That is first assess the STS score and assess the Euro score, and assess the in-hospital mortality rate, assess the 30-day mortality rate, and the syntax score assess. You decide whether syntax he belongs to low risk group, low score, that is 22, or intermediate 22, 32, or more than 33, high syntax score. So another most important point is aim for complete revascularization. So these criteria you should consider when you are choosing the option of a PCI versus bypass for left main patients. IVAS guidance, this was published by HFrecEF. Angio guided versus IVAS was compared, the mortality rate 13.6% versus 6%. That means IVAS significantly improves the outcomes. Whether to choose left main for left main patients for PCR bypass, always assess the STS score, assess the Euro score and syntax score, and based upon that you can choose whether patient will get benefited with bypass or PCI. Left main disease with a low syntax score, that is 0 to 22, bypass as well as PCI, both comes under class 1A. That intermediate score, bypass 1A and PCI 2A, and left main disease with high syntax score, definitely PCI is contraindicated. That comes under class 3. Best in class death, optimal pharmacotherapy, very, very important. Image guidance and physiological assessment is very, very important. Imaging to optimize the results, very important. Always see that adaptive you are continuing or not, and statin preloading. And if the patient is having any atrial fibrillation, add anticoagulation therapy also. Choose whether the provisional stenting or two-stent technique. If really two-stent technique is preferable, in that case, choose the TK crush over the other stents because of the more favorable data. Calcium is significant. Try to do the debulking. And if the LV dysfunction is there, single surviving vessel is there, then go with the hemodynamic support. And to avoid the CAN, better to stage the procedure if you are doing the left main with the multi-vessel. And routine angiographic follow-ups is definitely required to provide the best long-term results. Hard time approach, that decisions based on STS score, Euro score, syntax score, and also assess the comorbidities. And wherever needed, assess the significant lesion is there or not. Image guidance for assessment of the block and optimization of the test results. Very, very important. Above all, you discuss with the patient in detail and explain the pros and cons, and then make the decision based upon their preference and choices. Thank you one and all for paying the attention.
That was Dr. Sridhar Kasturi from Hyderabad. Wonderful talk on CABG versus PCI option in patients with left main disease. I would like to ask you one question, a real world scenario. Let us say a 60-year-old gentleman comes to you with left main disease. what are the factors that you would consider before deciding with the syntax score around about 23, 24? What are the other factors you would consider before you choose between PCI versus CABG? We all know that you are a high volume operator and you're highly skilled, but then there would be some factors you would give a lot of preference to before you decide PCI versus CABG. Can you tell us about it?
Yeah, first of all, that's very nice show, excellent narration. And before choosing, always see like in addition to, as I said earlier, STS score, Euro score, and comorbidities like a COPD is there, carotid disease, then peripheral vascular disease. And cost effective is also very, very important. Suppose if you are using a left main disease, you have to do the like imaging. When imaging, without imaging, definitely stent thrombosis and ISR is more. So the affordability, everything we will discuss. Now many states, like southern states particularly, they are providing the cost-effective health schemes. Really, the very comorbidities are not that good, not like COPD is not there, like peripheral vascular disease is not there, is ideally suitable candidates, because distal targets are there. Financially not that affordable, I don't mind. I will encourage him to go with the bypass. Even today, first choice, diabetes is there, I prefer him to go for bypass surgery. Still, if the person is not willing, family member not opting, then only I will think of but preferable to go ahead with the bypass even today, because most effective long-term TLR, everything, he can't afford, like a repeat revascularization, everything. The first choice is always bypass. And we'll discuss with the team if the patient is not willing. If he's, when we are doing procedure, definitely he has to, we have to do with imaging, whatever best part, like if the calcium is there, plaque modification, everything you have to do it, then definitely cost escalation will be there. So we have to consider all those points before deciding the strategy for the patient.
Thank you very much for that detailed explanation. Just one more question. Patients who has had left main PCI comes back to you with restenosis, then would you consider redo PCI or CABG? What are the points you would ponder about before we decide on your next strategy?
We do many times, they come with the restenosis. Sometimes they come, previous imaging was not done. Sometimes the technique may not be proper. The restenosis may not be, we have to see the etiology exactly. Is it because they missed the proximal edge restenosis is there, distal edge restenosis is there, stent under expansion is there. If these correctable factors are there, definitely repeat PCI carries very good prognosis. Suppose the edge restenosis is there, they extremely good. Sometimes when you are doing the left main, you have missed the ostial left main. Sometimes if you are doing the T-stenting, if you are missing the ostial left circumflex, that time you can do with additional like a DEB and further expansion, under expansion, further expansion is there. So if the calcium is there, not expanded well, if you do high open NC pressure inflations or IVL for under expanded stents, definitely that scores well. Obvious cause of stent fracture is there. Again, restenting definitely it helps. But again, I always see the cost effectiveness. But repeat revascularization compulsory, it's mandatory to use the imaging. First, we should know the etiology and why the ISR took place. Is it because the stent, suppose already BMS, sometimes previously underwent PCI with first generation coming back, that also is an option. But ISR, first choice again, bypass left main. Still, if the patient is not willing, then you can think of the other option based upon the etiology.
Thank you very much, Dr. Sridhar Kasturi from our MANIPAL Cardiology Update team. We really appreciate the time you spend with us and your words. Let us move to the next topic. Dr. B.C. Srinivas will give us a talk on his topic, heart failure with recovered ejection fraction. Let us listen to Dr. B.C. Srinivas from Bangalore.
At the outset, I thank Maha University and Dr. Tom Devasi and his team for inviting me for this lecture and this webinar. This is a new topic, heart failure with recovered ejection fraction is a new topic. As all of us know, heart failure contributes to morbidity and mortality all over the globe, and guideline directed medical therapy and device therapy is actually improving the prognosis and the longevity of heart failure patients. While on guideline-directed medical therapy and device therapy, quite a substantial number of people actually recover their LV function and improve. And this particular group of improved ejection fraction is being called as heart failure with recovered ejection fraction. The expert panel of ACC provides the following working definition for HFrecEF. Documentation of LV ejection fraction of less than 40% at baseline with an absolute increase of more than 10% of LVEF with therapy and a second LVEF measurement being more than 40%. If you look at the epidemiology, the proportion of patients with HFrecEF varies widely, about 10 to 40%, depending upon the population studied. One of the first reports by Dr. Punos et al. Actually, prevalence of HFrecEF was about 34%. And in fact, if you look at the data, 70% of patients actually labeled as HF preserved ejection fraction and documentation of prior HFrecEF, that is their heart failure with reduced ejection fraction, suggesting that quite a few of them actually had reduced ejection fraction in the past. Similarly, if you look at the data from Emory University, nearly 16% of the patients with baseline LVEF less than 50% actually recovered their LVEF with guideline-directed medical therapy. There is another name, that is HF mid-range EF, which is endorsed by the European Society of Cardiology, a new category of heart failure. And this group is actually a heterogeneous group. Actually, it represents an admixture of both heart failure with reduced ejection fraction who has been treated where the LVEF has improved, and those with heart failure with preserved ejection fraction whose LVEF has actually declined over time. So if we look at the biology of reverse remodeling and recovery of ventricular function, reverse LV remodeling refers to restoration of more normal cardiac myocyte size and LV chamber hypertrophy, resulting in leftward shift of the end-diastolic pressure-volume relationship towards normal values. This is associated with improved myocyte contractility and improved LV chamber contractility. And it is clinically associated with fewer heart failure hospitalization and decreased cardiovascular mortality. And there is direct correlation between the extent of LV reverse remodeling and improvement in cardiac survival. Cardiac remodeling is a dynamic process which can occur in bidirectional manner, both forward as well as reverse. There is a coordinated regulation of multiple molecular and cellular changes that contribute to phenotypic changes in the size, shape, and function of the heart, which actually can result in either improvement or deterioration of clinical status. Basic and clinical studies have shown that many of these cellular and anatomic changes which occur during forward LV remodeling actually start reverting towards the normal, less pathologic phenotype during the reverse LV remodeling, though not complete normally. This is to schematically show you that patients with, for example, here you can see with normal heart with an insult, it could be an inflammatory insult, ischemic insult, or it could be toxic insult or a hemodynamic overload, it remodels. And this remodeled heart with the constellation of signs and symptoms, we call it as clinical syndrome of heart failure. With guideline-directed medical therapy and device therapy, we can have normalization of the left ventricle over time with ejection fraction fully recovering to more than 50%, or partial recovery with treatment with EF ranging between 40 to 50%, or it may not recover at all depending upon the amount of initial damage the patient had. So if you look at the effect of various guideline-directed medical therapies, that is beta blocker, ACE inhibitor, ARB, aldosterone antagonist, the LV assist device, the cardiac resynchronization therapy, and the cardiac assist devices, they have an impact on multiple levels. At the myocyte level, that is, they can affect the hypertrophy, gene expression, cytolysis can be inhibited, beta adenine desensitization, we are well aware with beta blocker it decreases, the excitation contraction coupling improves, and in fact the aldosterone antagonists increase the cytoskeletal proteins So similarly, even at myocardial level, the myocyte apoptosis can decrease, the activation of matrix metallus proteinase can decrease, fibrosis will be inhibited, angiogenesis will be promoted, LV geometry changes. So we are all aware that these are influenced by the existing guideline-directed medical therapy and the device therapy. Reverse LV remodeling, which occurs with treatment, is not simply a mirror image of the molecular and cellular pathways that become dysregulated during forward LV remodeling. It is a very well coordinated multi-level process that allows the heart to adapt to a new, less pathological steady state. I want you to appreciate that it is not complete normalization, but it is a new, less pathological steady state. So that means the footprints of the initial damage will remain though the ejection fraction normalizes. So what you need to know is there is retention of many molecular features of the failing heart, which can cause a future long-term recurrence of heart failure, even in those who have recovered their ejection fraction. These are some of the common etiologies which cause reversible heart failure. Abnormal energetics is one of the common reversible causes. Apart from that, we know toxic insults, inflammatory diseases, excessive hemodynamic stress, and even excess neurohormone activation can cause reversible. For example, if you look at the toxic insults, anthracycline, the trastuzumab, that is the monoclonal antibodies which are used for the breast cancer, we know that these chemotherapy agents, when instituted for cancer therapy, can cause toxic myocarditis with heart failure. And by withdrawing these medicines, actually the toxic myocarditis reverse LV function improves. Similarly, we know that alcohol-related cardiomyopathy, to significant, almost in 70% of them, it normalizes. Even in peripartin cardiomyopathy, we have a significant reversal of ejection fraction. In fact, it can normalize in more than 70% of them. Similarly, if we look at the immune response, pathological like viral myocarditis, acute lymphocytic myocarditis, the modes, sepsis, these are other situations where immune attack on the heart muscle can weaken the heart, resulting in heart failure, but they do recover with treatment. Similarly, we have the excess neurohormonal stress, like the prototype is the Takotsubo cardiomyopathy, and others are the pheochromocytoma, recreational sympathomimetic drugs like cocaine, amphetamines, ecstasy-causing drugs. These also are known to cause toxic injury to the heart muscle, resulting in heart failure, but they all can recover. Similarly, if we have excessive hemodynamic load, for example, is uncontrolled hypertension, severe aortic stenosis, coarctation of aorta. By treating this, there is reversal of heart failure. And other great examples are the abnormal energetics as seen in the thyroid disorders, tachycardiomyopathy in the setting of arrhythmias. These are also reversible heart failures. I'll give an example. This was a 79-year-old woman with breast cancer treated with the trastuzumab, and you can see that the endoastolic and systolic frames of LV dilated, where the ejection fraction was 33%. After withdrawal of the chemotherapy agent and guideline-directed medical therapy, you can see that normalization of the left function with EF returning normally. It was another case of example, hypertensive heart disease with severe LV dysfunction presenting with heart failure. It was also consuming alcohol. By treating hypertension as well as by stopping the alcohol consumption, that you can see that the endostolic volume recovered, the ejection fraction improved. It is a matter of a year. It went on to have normal ventricle. Is another example. This was adrenal insufficiency with LV dysfunction in young male, and you can see that after replacement therapy with hydrocortisone, the LVEF normalized. So we have many cases. This another example. Tachycardiomyopathy with a severe LV dysfunction, severe heart failure, ejection fraction was only 9% in this. This was it was an atrial tachycardia going on in a 44-year-old male presenting as a DCM. But when we restore the sinus rhythm, you can see that the M-mode image, how the LV is normalized. And in this individual, if you look at the strain imaging, there was a time lag between the septal and the lateral wall contractility, almost to the tune of 224 milliseconds. Immediately after ablation of the arrhythmia, you see that the dysynchrony is reduced by almost half. And these cases actually, they improve over time rapidly. These tachycardiomyopathy patients actually improve very rapidly. So if we look at the prognosis of these patients, heart failure with recovered ejection fraction, they have a 50% decrease in the hospitalization and better survival compared to those with heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. And even the long-term requirement of cardiac transplant, etc., replacement therapy is also lesser. So if we look at the various data, the incidence varies about 9 to 30% of patients treated with heart failure actually will become recovered heart failure patients. That is the recovered ejection fraction patients. But if we look at the baseline characteristics in these studies, which have looked at the recovery of LV function in patients treated with guideline-directed medical therapy for heart failure, these patients typically have lesser comorbidities. Number one, they are younger, they are having shorter duration of heart failure therapy, and they are having smaller LV dimensions and LV volumes at the presentation, and majority of them are young, as you can see. So to summarize, the predicting factors for LV reverse remodeling in patients with reduced ejection fraction: non-ischemic etiology, shorter duration of heart failure, females, and absence of LBB on ECG. If there is LBB on ECG, if they are on CRT, it's a strong predictor of reverse LV remodeling. And similarly, people have looked at the genetic factors. If there are genetic variants involving structural cytoskeletal proteins or Z-disc proteins, they have a worse prognosis. If they're not involving this, they have a better prognosis. Similarly, if someone has very low ejection fraction, but strain imaging, if it shows good contractility, they have a better prognosis. And similarly, cardiac MR showing absence of late gadolinium enhancement, that is suggestive of scar burden, lesser scar burden has better prognosis. Similarly, biomarkers, if you look at lower NT-proBNP, lower troponin levels, and lower soluble T levels, ST2 levels, lower galactose-3 levels have a better prognosis in the long run with respect to recovery of ejection fraction. What is the natural history of these patients? If we look at the natural history, significant proportion can develop recurrent LV dysfunction, though they have normalization of LV function over time. And this is because the biochemical and the molecular studies done in these patients have shown that there is retention of many molecular features of the reverse remodeled heart. So though the LV starts remodeling, it doesn't normalize. It ends up in a transition zone where there is a new, less pathological steady state. This you have to remember. This happens because of the persistent dysregulation of the transcriptome, metabolome, and proteome of the cardiac myocytes, and the progressive erosion of the native three-dimensional organization of the extracellular matrix. This is the reason why it may not be advised to stop the guideline-directed medical therapy, though there is an improvement and normalization of ejection fraction. How do we manage these patients? Though they are normal with respect to ejection fraction, biochemically and molecular level, they may not be normal. So none of us are aware, as on today, management protocol, as we don't have a robust prospective data. If there is persistent exertional dyspnea, JVP, and fluid overload state in this group, we need to definitely look at it and then continue diuretic therapy. If the ECG, if there is absence of LBB, it's a good predictor. But if LBB is there, it's a good predictor for CRT. And in fact, even if you continue guideline-directed medical therapy in patients with LBB, the improvement will not be remarkable until the time you do a CRT. And people have looked at risk of sudden cardiac death in those patients with recovered left ventricular ejection fraction, and they have shown that if there is pathologic mutations in DSP, SCN, 5A, LMNA, FLNC, they are at high risk for malignant arrhythmias compared to other genetic and non-genetic etiologies of TCM. And people have looked at biomarkers level. If there is greater reduction in the proBNP with GDMT is associated with greater improvements in left ventricular ejection fraction, greater reduction in LV volumes, and improved clinical outcomes. And risk of recurrent LV dysfunction actually, we can actually analyze in these patients by serially measuring specific biomarkers over time. It's important to measure the biomarkers over time during follow-up. And if you look at the echocardiography, there will be decreased LV end systolic and diastolic volumes, ejection fraction improves, and the functional MR reduces. RV is usually normal in these cases. Though there is an improvement grossly of the myocardial functioning, if you carefully look at the myocardial strain and the diastolic function, they rarely normalize in this group of heart failure with recovered ejection fraction. This is the point to remember. However, if they have higher global longitudinal strain, what has been noted is that the LVEF remains stable during follow-up. So if someone has recovered ejection fraction with a good global strain pattern, longitudinal global strain, it's a good indicator of better long-term survival. Similarly, CMR showing the scar burden also has an impact of the recurrent heart failure in this subgroup. They have shown that absence of late gadolinium enhancement, which is suggestive of the scar, in both ischemic and non-ischemic cardiomyopathy, is a strong predictor of recovery remodeling and is associated with improved prognosis. Similarly, people have also noted with during CMR T1 mapping to measure extracellular volume and interstitial fibrosis is another promising indicator, a predictor of response to therapy and improved prognostication in heart failure. How do we follow up these patients with recovered ejection fraction? It is mandatory that we see them at least every 6 months, especially clinically examine them and do an ECG and do a biomarker evaluation at 6 months. This gives us an idea. If NT-proBNP is elevated, it indicates that some sort of mechanistic stress is there to the left ventricle. So you need to follow them more closely and continue guideline-directed medical therapy in such patients. Echocardiography is preferred at every 1 year. CMR at least once in 3 years. This is to know the scar burden. In some cases where there is genetic cardiomyopathy, in such cases, Holter monitoring is also recommended. So patients with higher risk, that is those with persistent LBB, genetic dilated cardiomyopathies, and those who have higher biomarker profile and more comorbidities, these are the groups who should be selected for shorter interval of follow-up as well as imaging. And you should, in addition, you should also remember that heart failure with recovered ejection patients also can develop coronary artery disease, new onset of atrial fibrillation, which can worsen the existing clinical condition. This is another thing. Treatment of heart failure with recovered ejection fraction, if you look at people who in red heart failure, when they stopped the guideline-directed medical therapy, 40% of patients actually had recurrence of heart failure. So this is a data which has come from red heart failure. Similarly, in another group of toxic myocarditis, when GDMT was withdrawn, there was recurrence of heart failure over time. And this happens in the first few months rather than the first few days or weeks. Cessation of diuretics is encouraged because most of these patients do not require diuretic therapy. And ability to tolerate lack of diuretics is a very good indicator of lower risk of recrudescent heart failure in these individuals. RAS blockade should be continued. In fact, if you look at the paradigm and the paragon heart failure, even mildly reduced heart failure patients also benefit with sacubitril valsartan therapy. Most patients with mid-range ejection fraction, which actually includes the majority of the HFrecEF, in fact, benefit with sacubitril valsartan therapy. Hence, RAS inhibition should be continued in this group, apart from beta blockade. We know that revascularization in the setting of coronary artery disease improves the myocardial stunning and hibernation, and both medical and catheter-based revascularization techniques actually are known to significantly improve the reverse remodeling in patients with chronic IHT and heart failure. And of course, the imaging with CMR and PET, in fact, gives us an idea regarding the viable myocardial segments, which are more likely to improve with revascularization. A word about ICD. Those who are already on ICD, it is recommended that they continue to be on ICD, especially if there are higher risks such as if there are positive genes for LMNA, SCN5, and FLNC. So, and if they are on CRT, we all of us know withdrawal of CRT in the patients with improved ejection fraction in the setting of LVB causes electrical dyssynchrony and worsening of LV function. So, CRT should be maintained in those with, people with electrical dyssynchrony, though they have recovered their ejection fraction. Gaps in knowledge and future perspective, if you look at, there are many gaps in knowledge because we don't know about the biology, natural history, and long-term clinical outcomes of these patients because this is a new entity which is being recognized. So to conclude, it is a new designation for heart failure with improved ejection fraction following guideline-directed medical therapy. Though ejection fraction improves, the molecular footprints of myocardial dysfunction actually remain, making them vulnerable for future deterioration. Continuing guideline-directed medical therapy is recommended at present. Follow-up at regular intervals for recurrence is mandatory, but gaps in the knowledge remain, which will be addressed in the near future. I thank once again all the participants in this webinar. Thank you.
That was Dr. B.C. Srinivas from Bangalore. Thank you very much for your wonderful presentation. Just wanted to ask you one real world scenario. A patient who had a documented EF of 30% in the past has been on beta blocker and ARNI, symptom-free, normal coronaries. NT-proBNP now is 150, and they are requesting to reduce the dose of drugs if possible. How do we take it from there?
Tom, at the outset, I would like to thank you again for giving me the opportunity to participate in this webinar. But coming to the patient in this question, I would convince him to continue the medical therapy. There is no doubt. If at all, see, if the ejection fraction improves and if he is asymptomatic, I would like to reduce the diuretic therapy because that is one thing which we can do and we can try. And then, but continuing the neurohormone blockade is extremely important because withdrawal of beta blocker, withdrawal of ARB or the ACE inhibitor or RNA in this scenario, what has been shown that they may have, it may remain normal for about few weeks, even maybe a few months, but once they develop recurrence of LV or deterioration of recurrent LV deterioration, what has been noted is the recurrence is associated with irreversible damage to the heart muscle. So that means the chance of recovery of LVEF with a second treatment is gone. So it is extremely important to highlight this factor. So in fact, the same thing has been noted in a couple of studies. Actually, these are short studies. We don't have a long-term, long large number patient data, but the data is very clear that recurrences are, when it happens with withdrawal of therapy, is going to be bad. And it also depends on the comorbidities. If there are more number of comorbidities, I think those are the cases where the recurrences are going to be higher. I don't think we should withdraw, especially if it is ischemic cardiomyopathy. If he has improved, LV has normalized, I don't think we should withdraw therapy. Yes. Similarly, one situation where you can stop is, where the energetics, like a tachycardiomyopathy, you treated the arrhythmia, LV has normalized. That is one scenario, maybe, where you can stop the treatment totally, probably, when you have treated the arrhythmia completely.
Absolutely. So the triggering factor plays a very important role in deciding about medical optimization. Thank you very much, Dr. B.C. Srinivas. We really appreciate the time you spend with us. And thank you very much for your wonderful words. Have a nice day ahead.
Thank you. Thank you. Thanks, everyone.
We move to the next talk by Professor Zulfikar from Trivandrum on congenital heart disease and the role of stents. Let us hear it from him.
Good evening. I bring you great wishes to Karnataka and KMC Manipal on this occasion of combined birthday of our states. We will have a brief discussion on the use of stents in congenital heart disease today, along with basically an adult kind of a cardiology discussion. And at the outset, I would like to have a disclaimer because I do not do stenting procedures right now, and I will concentrate less on procedural cardiology of stent deployment and try to offer an overview of the topic and sensitize the cardiac and other disciplines who are present here in medical care regarding the expanding role of stents in the care of children with congenital heart disease. If you start with the definition, we could always say that the stent is an endovascular splint or a scaffold for maintaining the lumen with minimal recoil and good radial pressure. And we should look at the origin of stents, like origin of species. And the term stent, the noun comes from a word called stenten, which means a stake for stretching out fishing nets over the river. Some of you must have seen this kind of nets in Cochin. And it's a verb, it's basically a stretching out the sail curtain. This is the origin of this particular word. But our stent is basically derived from a dental surgeon who is Charles Thomas Stent in UK, and he produced a stents compound to support the dental procedures, and that support system became the term stent. And the stent was first used in 1964 by these two, Dio, Daughter, and Judkins. And the stent in coronary for the first time was put in 86, and the first time a stent was put in a congenital heart disease was in 87. And you can see the Palmas is our man. And Rashkin, of course, has to be remembered because he was the person who, for the first time, intervened in a congenital heart disease. So I would like to start with what we call as a current perspectives in the stent. What do they achieve or what do they do? One, they provide a radial force to prevent elastic recoil. They compress dissection flap against the lumen wall, make it smooth. Maintains a higher diameter naturally, and of course is useful in long segment obstruction. And these stents can open up native obstruction, reobstruction, or obstruction caused to a man-made connection. All these things the stents can do, and this is universal. It can work in a newborn, in an infant, in a child, or in an adult, or a native problem, or a post-operative issues. And the materials are usually divided in two groups. One is a balloon expandable and a self-expanding. Majority would be a balloon expandable containing various kinds of metal, from simple stainless steel to very premium titanium and platinum. And this stenting procedure could be elective or emergent, and both emergent, especially in a newborn or a cyanotic spell, etc. Whereas elective can be on native problem or a post-operative problem. And I think the basic thing you must understand that the stent in congenital heart disease is essentially off-label most of the time, but it has been considered the standard of care from 1996 onwards. Probably the most common indication is pulmonary artery branch stenosis, followed by coarctation, and then, of course, two new things like RVOT stenting and ductal stenting, which could be, of course, followed by other vessel stenting, either artery or a vein, systemic or pulmonary vein, and various other things which we will discuss a little later. And when you start a procedure on stenting, the usual thing would be a history, physical examination, a chest X-ray, ECG, and echo, and a perfusion scan, especially when you are dealing with a unilateral pulmonary artery branch stenosis, sedation, heparin, antibiotic, and of course the procedure with the standard items and hardware. The first one, number one, is a pulmonary artery branch stenosis, which is the most popular indication. It could be done for a bilateral pulmonary artery stenosis or a unilateral pulmonary artery stenosis, depending upon the perfusion scan result, that length scan. And it would definitely increase the diameter, decrease the gradient, decrease the RV pressure, and definitely improvement in lung perfusion. So I think what they do is that they prevent recurrence due to a less of elastic recoil, and definitely promote PA. That is very important for a child due to maintaining the radial strength. And this could be offered usually percutaneously, but some people have done intraoperative as a part of a hybrid procedure. And this is a stent, is basically a severe proximal pulmonary artery branch stenosis, which could be tackled by this thing. And the usual complications of balloon stenting would be migration, malposition, and sometimes embolization. So you have to retrieve this. Then rare but dangerous complication would be acute pulmonary edema, especially in a unilateral pulmonary artery branch stenosis and arrhythmia. Now, the second, perhaps the most common indication is for the fourth most common congenital heart disease, that is coarctation. Initially, we used to do with hesitation, balloon dilatation in a recoarctation and followed by a native coarctation. But now, native coarctation is offered a stent procedure, especially in an older child and in an adult as a routine standard thing. We do a stenting above the gradient of 20 millimeter, and post-procedure, what we expect, gradient of less than 20, naturally, improvement in diameter, and patient should be on antiplatelet drugs. And the coarctation stent is particularly useful in a long segment, hypoplastic isthmus, tortuous coarctation, as in rubella also, and of course in recurrence. And generally, we tend to do coarctation stenting beyond 10 years because child would have been around 25 kilogram or so, because the abdominal aortic size will match almost the abdominal aortic size of an adult, and the results are exquisite, very good results. So we have actually three things which can be offered to a coarctation, native coarctation, that is surgery, the standard of care, balloon, not very popular now, and stent is a very popular now, especially in an older child. And it favorably compares with the surgical results. But there may be some wall complications like rupture, dissection, and aneurysm. You can see a very discrete, severe coarctation here. You can see an attempt to crossing, again a narrow segment, and you have put already a stent in this particular patient, which is actually a post-operative patient, probably must have an aortic procedure. Anyway, now we come to another very important area where you talk about a newborn baby, infant with pulmonary atresia. We used to do regularly a neonatal beatation. It is increasingly being done less. Now the ductal stenting, it's not stenosis, ductal stenting is the choice of generally. And next we may go even for a RVOT stenting. This ductal stenting is primarily meant for a duct-dependent lesion on the right side, which produce hypoxemia, on the left side, which produce a poor perfusion. And mostly is on the right side, you have pulmonary atresia, a single ventricle with pulmonary atresia, TGA, which is dependent upon the ductus, and that can remain in station for at least 6 to. This is a procedure where you have a ductal stent in place, very nicely. Then RVOT stenting is the next new thing, which opens up RVOT as a bridge, of course, and it also opens up the bioprosthetic RVOT conduit, which is present in many of the complex congenital heart disease. This is a simple RVOT stenting in an older child or an infant. This is another view, lateral view of a stenting. Then we have, this is critical newborn, very small pulmonary arteries, and is just able to cross the RVOT and put a stent there. And you can see definitely an improvement in the blood flow, and probably the pulmonary size also will become improved, so that at some point of time, maybe at 3 months or 6 months, we can do a BT shunt. So regarding the comparison between the PDA stent, RVOT stent, and the bladectomic Thomas shunt, one is old, of course, but it's still remaining. Procedural death is definitely more common in BT shunt. Complications are a little more, least would be probably in a RVOT stenting. So right now, the ductal stenting may be the today's theme or a menu, whereas tomorrow probably, because RVOT is stenting more physiologically, and we have also the support of ductus, because many of them will have a ductus, we can do it little more comfortably in the lab. And in an emergency situation, I think this is very important in ductus dependent lesion. Now we have post-operative stenting, especially in a tautology pulmonary atresia situation, where the patient would have already had a VT shunt, a blocked, or a RVPA conduit as the final procedure, and sometimes you need to augment the RV outflow. So this is a blocked VT shunt which could be tackled with a stent. Then post-operative stenting would be also important in more complex heart disease like a TGA and a truncus. You can see a post-ASO pulmonary artery branch stenosis which could be tackled by a stent. RVPA conduit in many conditions, including truncus, which can. Recently, we had a univentricular heart who had a conduit which was blocked and planning for a balloon stent procedure. And of course, a gland can be get obstructed and cause problems. We have a stenosed MAPCA because some of the MAPCA may be useful to maintain the blood supply to the lung when we deal with them as a conservative management rather than a surgical management. And of course, it's part of the melody implantation in the pulmonary valve replacement percutaneous. And pulmonary vein stenosis following TAPVC, there is some problem in the post-operative pulmonary vein stenting here. But we must always be aware of the adverse events that can occur. You can have major problems like a stroke or a pulmonary edema or a hypertension, less major problem like hemothorax, stent migration, and stent malposition. Now, this gentleman, I think most of you know, the Star Wars fans will know. This is called C3PO project, that is congenital cardiac catheterization, 3CPO, that is project on outcome, which has come out, devised a method, a risk assessment method, which is called CHARM, to decide whether a particular intervention procedure with the stent or otherwise is of a low risk or a middle risk or a high risk. And then I will offer you some experience from France. France is very important for this kind of procedures. It's now become little into limelight now because of wrong reasons. But anyway, they have done stenting procedures and all the other procedures from 5 days to 70 years. And most of the indications are the same which we discussed: coarctation, pulmonary artery branch stenosis, ductal stenting, and of course part of valve. This thing success has been very high. Adverse reactions are modest, and it is much more common in adults because of an elderly adult. Boston experience also shows that the most common indications are 3: branch stenosis, RV obstruction, and coarctation of aorta. And we can also have an intraoperative stenting as a part of a hybrid procedure. Now we come to the second part, which is what you call as a future perspective, which has been given to me. Where do we go now from this particular point? That is what COVADIS is. And these are emerging indications, emerging materials, and emerging concepts are there. Evolving indications, or what you call as an emerging indication, is a maintenance of patency of ductus, as we already seen. ASD, suppose you do an ASD, small ASD is made in an IPH or a VSD, RVOT stenting, post RF ablation of a critical membranous pulmonary stenosis, MAPCA stenting, which we discussed, vertical vein stenting, infracardiac obstruction stenting, and pulmonary venous stenting, which again we discussed, especially if a post-transplant application, because children are slowly getting into a transplant situation. Regarding the stents, I think the future remains. There are 4 important futuristic stents. One is a bioabsorbable stent, which maintain the scaffolding for some time, like 6 months, by the time it adapts the growth and should not restrict future surgical intervention. And it could be done in a coarctation or pulmonary artery branch stenosis, whereas different materials. One is a polymer, then there are some metals also, magnesium, magnesium is there, and it's a very soft. Recently I learned that magnesium is very soft because I was studying my grandson's chemistry textbook. Magnesium is easily corrodable, and data in coronaries have come in 2005, and in the newborn it could be particularly useful because it facilitates vessel growth and it is favorable for future surgery. It could also be used in a coarctation pulmonary artery branch stenosis. Then the growth stent is a stent which has 2 separate longitudinal halves. You can imagine 2 separate halves linked to the is with the bioabsorbable sutures which would absorb in 6 months, so that it will grow and will remain as a stent. It could be used in a long segment pre-coarctation. And finally, I think drug-eluting stent, when people do coronaries with drug-eluting, how can a pediatric intervention be far behind? So people are trying for a drug-eluting stent, especially in an RVOT stenting and venous stenting, pulmonary venous stenting in congenital heart disease like TAPVC. So that finishes an overall future perspective of stenting. And I would like to thank Dr. Deepa, who was my erstwhile student and now an associate professor in Chitra, who have given me the pixels and also given me some insight into intervention. In fact, she had published a paper in 2020 on early and late outcome of covered and non-covered stents in treatment of coarctation of aorta. And there are many other studies I would like to mention, from Feltis to Uzel to Shivakumar is another person from Chitra, my student, and Forbes, Peters. We can go through this. The student population of KMC, that meeting, can always go through these major, because it is none. P.S. Rao is there, Qureshi is there, so many people are there, Locke is there, so good references you can take at leisure. Because it is a recording, you can always go back into this. And thank you very much this evening, and particularly thankful to Tom, my dear friend, and Dr. Sudhakar, my dearer, or not, I would not say dearer, but I am very, very close friend, because even though much younger to me, we talked almost on an equal term, at least I do. And thank you, Sudhakar, for the trouble you have taken. We know what kind of trouble you have taken. So thank you again. And thank God, who is the cherisher and sustainer of all worlds. Thank you very much.
That was Professor Zulfikar Ahmed on role of stents in congenital heart disease. Thank you very much, sir. I would like to know a few common clinical scenarios wherein you would give preference to management of the problem with a stent over surgery, especially in your region.
I think the probably the most important indication of situation where we have to do a stenting or a BT shunt or a ductal stenting is the tautology situations with pulmonary atresia with a relatively poor pulmonary artery. And as you know very well, the number of BT shunt is coming down. The experience with the younger surgeons with BT shunt is also coming down, and which means maybe a slightly enhanced mortality. So which naturally people would tend to go for a ductal stenting or RVOT stenting. And if you have a ductal stenting, there is one risk, because that is the only precarious source of blood to the lung. And if you happen to have some crashing, the baby will crash. It cannot come out. Whereas if you do an RV stenting, what happens is that there is a ductus already mostly, and it will to some extent protect it, and you can save the day. So what has happened was some time back, we all remember maybe 5 or 6 years back, there was always a tussle between the surgeon and the interventionist whether the ductal stenting is superior or BT shunt is superior. Now it has become another question, that is whether ductal stenting is superior or RVOT stenting is superior. So that is one classical example where the stenting would be of a genuine use. I think that is one example. And secondly, when we did DM in the early 90s, ancient times, that is around 30 years back, the standard management for a coarctation, native coarctation, was surgery. And at that time, just in India, people are just starting to do a balloon procedure for a coarctation, and which was actually looked down upon. Nowadays, what is happening is that at least in older children and adolescents and adults, we generally offer stenting as a procedure of choice, even though the surgeons may not fully, endorse that kind of view. So these are two situations where I think stenting would be And of course, pulmonary artery branch stenosis remains the what you call as the standard thing, where surgery is not at all feasible most times, and there's a problem with the recoil in simple balloon. I think these are the three situations, I think, Tom, that this is definitely superior.
Thank you very much, sir. We really enjoyed the views you have given us, and we thank you from MANIPAL Cardiology Update for joining us for the program.
Thank you, Tom. You are eternally young and handsome.
Thank you very much. Thank you.
Thank you. Good night.
That was Professor Zulfikar Ahmad from Trivandrum giving us a talk on the role of stents in congenital heart disease. We will move to the next topic by Dr. Sarjan Ahmad Zed. He is talking on non-STA elevation MI. How do you manage recent prospects? Let's hear from him.
Hi, good evening, everyone. It's good to be back at KMC Manipal, even though on the virtual platform. Special thanks to Tom sir and Dr. Sudhakar for the invitation. I feel that sometimes new guidelines are like new products on the market. Some have striking features which proclaim new, while some, you have to search really hard to find out the difference. So that brings us to what is new in NSTEMI management in 2020. And as our organizing chairman, Tom sir, who happens to be getting younger and younger with each passing year, mentioned to me over phone, if at all there is something new in 2020. So we know that right from the pathological basis, NSTEMI and STEMI have got similarities and differences, and it extends to the clinical outcomes also, so much so that they both are called the dangerous brothers. So what we'll do today is look at the latest 2020 ESC and STEMI guidelines and look at what medical treatment, angiography, intervention, and surgery have to offer to the patient, and look specifically at spontaneous coronary artery dissection and MINOCA is a new term, and which have been given special relevance in the new guidelines, and try to conclude with some perspective. So this is the 2020 ESC guidelines, and straight away the name is new. It's not really NSTEMI now, it is NSTE ACS, so non-ST elevation ACS. And the guideline has given a management strategy which includes 6 steps, which starts off with an initial evaluation pathway, a diagnosis, validation, and risk, antithrombotic treatment, invasive versus selective invasive, and how to choose the revascularization mode, and finally about discharge and post-discharge care. So step 1 is about initial evaluation, where of course in most hospitals it happens in the emergency department now with the evolution of the field. And so this is where it happens, and it usually involves clinical assessment. First of all, very extremely important. Then we go to the ECG and have the troponin estimation. And in ECG, we look at the ST depression and TVA inversion criteria based on the guidelines. So now coming to the crux of the issue, the high sensitivity troponin, which is actually measured in a nanogram per liter, it has got a high negative predictive value for acute myocardial infarction. So what happens is, as the test becomes more and more sensitive and precise, we tend to diagnose more of non-ST elevation ACS and less of unstable angina. And if you have more than 5 times elevation of the troponin value, it has got a very high positive predictive value of 90% for diagnosing a myocardial infarction. So essentially you have a rule out or a rule in with high sensitivity troponin, which you measure at 0 hour, that is the first value, and then you have 1 hour, 2 hour, and 3 hour, depending upon the test that we use. But at the same time, not all chest pains who come to the ED ACS. So just like all troponin elevation is not due to myocardial infarction. This is in fact an inflammation that is affecting a lot of people among us, and probably more prevalent than the COVID pandemic. Now, what about imaging? Echocardiography has an integral role in the initial evaluation, especially if the patient is having hemodynamic instability, to rule out mechanical complications, and also to rule out differential diagnosis. In patients who present with NSTE ACS up to 24 hours or PCI, whichever is earlier, they have to undergo continuous rhythm monitoring, and this has to extend beyond 24 hours if the patient belongs to a high-risk category. The step 2 is a diagnosis validation and risk assessment, which in fact has 3 components. One is the serial HS-trophy. So in addition to the diagnostic value, you measure the serial values and ascribe prognostic importance to it. Then class 2A recommendation is for BNP and NT-proBNP, and for the GRACE risk score, which is a conglomerate of clinical, lab and ECG parameters. But at the same time, we shouldn't take evidence-based medicine too far, as in this patient in whom troponin values have been done twice daily for consecutive days. This does not make any sense. Now, coming to step 3, a very important component, antithrombotic treatment, which includes antiplatelet and anticoagulation treatment. All of us are very familiar with all the different kinds of agents that we have, but essentially how we choose these drugs depends upon the balance that we try to attain between the ischemic risk and the bleeding risk, which looks at patient characteristics, clinical presentation, comorbidities, co-medications, and also the procedural aspects. So for anticoagulation during PCI, unfractionated heparin is still the undisputed king, and then depending upon the bleeding risk of the patient, if it is low, high, or very high, we decide the antiplatelet and the anticoagulation strategy. So if you look at the standard, it is 12 months of DAPT, that is dual antiplatelet therapy for all patients unless there are contraindications. We'll come into details. Aspirin, of course, after an initial loading dose, 75 to 100 milligram once daily. Then we have the options of the P2Y2 inhibitors, which are clopidogrel, prasugrel, and ticagrelor. Clopidogrel at loading dose of 600 milligram and 75 milligram once daily maintenance dose. Prasugrel 60 milligram loading dose and a standard 10 milligram maintenance dose. And ticagrelor of 180 milligram loading dose and 90 milligram twice daily dose. Coming to the anticoagulation, for unfractionated heparin, the target range is 250 to 350 second of ACT during a PCI if GP2B3 inhibitors are not used, and lesser if they are used. In short, after PCI, for 1 year, all patients have to be on dual antiplatelet therapy unless there is a contraindication. If the patient has a high bleeding risk, we should consider stopping DAPT after 3 months, and de-escalation of antiplatelet therapy, that is from prasugrel to ticagrelor or ticagrelor to clopidogrel, may be considered in selected patients. Beyond 1 year, there is extended long-term secondary prevention with a dual antithrombotic agent, that is aspirin with another agent, has got a class 2A indication in patients who are at high ischemic risk and who are not at a high bleeding risk. Again, aspirin plus clopidogrel plus Rivoraxaban at a low dose, that is 2.5 milligram twice daily for 1 year, may be considered in ACS with high ischemic risk, low bleeding risk, and no prior history of CVA or TI. I'm sure we'll be discussing Rivoraxaban in another session. To identify patients who are at high bleeding risk, we have the ARC HBR criteria. If you have 1 major or 2 minor among all these factors, they are considered to be at high bleeding risk. So to reduce bleeding risk related to PCI, we should use the anticoagulation doses at the correct levels, radial artery approach as the default, proton pump inhibitors in patients who are at risk of GI bleed, that is advanced age dyspepsia, GERD, H. pylori, chronic alcohol, and in patients on OAC, take adequate precautions and avoid GP2B3 inhibitors unless it is a bailout strategy. Now, for extended dual treatment, we have, as I mentioned, the antiplatelet or the low-dose anticoagulation, and these are given in patients who are at high thrombotic risk, which is actually complex CAD with at least 1 criterion among the risk enhancers, or if the PCI is a complex one technically. So this is for extended treatment beyond 1 year. Now, in a patient who actually requires anticoagulation, for example, who has atrial fibrillation and who presents with an NSTEMI, we have to consider early CAG in high bleeding risk patients. This is very, very important message. It doesn't do much good to indefinitely postpone the angiography and work in a dark atmosphere rather than knowing the coronary anatomy. So it helps to expedite treatment allocation to medical versus PCI versus CABG, and if possible, it should be done early to risk stratify and to plan further treatment. So additional parenteral anticoagulation should be given during PCI, irrespective of timing of NOAC, and if the INR is less than 2.5 in somebody who is on a VKA. So if the patient has got an AF with NSTEMI and who's undergoing PCI. The standard recommendation is triple therapy, that is preferably NOAC, which is preferred over VK. If there is no contraindication, we can use either Apixaban 5 mg twice daily, or Dabigatran 110 or 150 BD, or Rivoraxaban at a dose of 20 or 15 mg once daily. So this can be combined with DAPT, that is aspirin with the P2Y12 receptor inhibitor for up to 1 week, and then up to 1 month, depending upon the selected cases, and up to 6 months in extremely high risk, high ischemic risk patients. But after 1 year, OAC NOAC alone is preferred after 12 months. But I'm not sure whether this is really practiced all over our country. Now, after 12 months, we may decide to give OAC with a single antiplatelet drug in selected high ischemic risk patients. And if you're using a single antiplatelet agent, a P2Y12 receptor inhibitor is preferred over aspirin. Now, this is a very very busy slide, but I would like to highlight only the last line. There is a use of ticagrelor or prasugrel as part of triple antithrombotic treatment is not recommended. So, aspirin with ticagrelor or prasugrel along with an anticoagulant is not recommended at all. So, that is a very, very important message. Now, if somebody is on vitamin K antagonist along with aspirin or clopidogrel, we may lower the target INR to 2 to 2.5 instead of the standard 2 to 3. And somebody is on medical treatment, OAC with single antiplatelet therapy is enough up to 1 year. And what about anemia? Blood transfusion should be considered if hematocrit is less than 25%, or if the hemoglobin is less than 8, or if the patient is having a compromised hemodynamic status. Now, how to decide on invasive versus selective invasive and when to do it, that is step 4. So, because the timing is extremely important in NSTEMI also, just like in ST elevation MI. So, if the patient presents to a PCI center and if the patient belongs to a very high risk, all these patients have to undergo immediate invasive strategy within 2 hours. That is, immediate invasive is 2 hours and early invasive is 1 day. So, immediate invasive less than 2 hours if it is very high risk. That includes hemodynamic instability, shock, recurrent or refractory chest pain despite medications, life-threatening arrhythmias, mechanical complications of MI, acute heart failure that is clearly related to the ACS, and significant ST change. If these are not there, if it is high risk, you can do the angiography within 24 hours. And if it is a very low risk, we can go for a selective invasive strategy after ischemia testing or a CT coronary angiography. Now, apart from scoring goals, the hand, I think very important role is for intervention nowadays. So, radial access is class 1 recommendation as per the guidelines, unless there are overriding procedural considerations. But we have to take the clinical picture into context also. Now, next, what kind of stent is to be used? The type of stent, naturally, it is drug-eluting stent for all, regardless of the bleeding risk or the anticipated duration of dual antiplatelet therapy. All patients should be on DES. Now, step 5, how to decide the mode of revasc. Again, in that, if you look at the factors favoring PCI to single vessel disease or clinical instability, while patients with diabetes, complex multivessel disease, and multivessel disease with LV systolic dysfunction, these are factors that favor coronary artery bypass grafting. Now, coming to SCAD, that is spontaneous coronary artery dissection, which has been dealt with separately. We know the types of SCAD. And if you have an obstructive and reduced coronary flow in a patient with SCAD, with persistent or recurrent angina or ischemia, it is an indication for revascularization. Otherwise, the decision can be individualized based on the intracoronary imaging findings, and medical therapy may be tried in patients who are really stable. The second area that has been covered is MINOCA, that is MI with non-obstructive coronary arteries, which the criteria include acute MI, non-obstructive coronary artery, that is no stenosis more than 50%, and no specific alternative diagnosis for the clinical presentation. This is the diagnostic algorithm, which essentially includes intravascular imaging with IVUS or OCT or cardiac MRI to detect specific patterns and also to rule out alternative diagnosis. So imaging is an integral component of evaluation of MINOCA, and CMR is given a class 1 recommendation in such patients. So NSTEMI with heart failure or cardiogenic shock, emergency CAG, emergency culprit PCI, are all class 1 indications, and IABP is class 2A, and mechanical circulatory support is 2B. The last point, routine immediate revascularization of non-culprit lesion, is a class 3 recommendation. All patients with NSTEMI should be screened for diabetes. We have to avoid hypoglycemia, and a less stringent control is advocated in advanced CVD, elderly, and patients with multiple comorbidities. Patients with chronic kidney disease, EGFR should be measured in everyone. Preferably use low or isoosmolar contrast with lowest volume, hydration with normal saline, and preference of CABG. Preference of CABG over PCI in multivessel CAD if acceptable surgical risk. Now, what about elderly? The same diagnostic and interventional strategies are recommended, but of course, conditions apply, because in our place, especially among octogenarians, many patients do not consent to interventions. What about step 6, that is discharge and post-discharge care? Lifestyle management has to be given due importance. Exercise rehabilitation is important, and annual influenza vaccine, often forgotten, should be prescribed, especially among the elderly. Acute care, of course, nitrates if there is ischemia, heart failure, or hypertension. Beta blockers unless there is frank heart failure or shock, and avoid beta blockers in case you are suspecting vasospasm as the etiology for ACS. Long-term drugs, statins should be given in all patients. Target LDL 50% reduction to below 55. If it doesn't get controlled after 4 to 6 weeks, add ezetimibe, and if it again after 4 to 6 weeks, consider PCSK9 inhibitors. Though I'm not sure how many patients can afford the drug in a country. Then target LDL maybe below 40 if there is recurrent ACS below 2 years. ACE inhibitors, ARBs, beta blockers, and MRAs, standard indications, heart failure, EF less than 40%, diabetic and CKD unless contraindicated for ACE-ARB. Now, what about proton pump inhibitors? Most patients would be eligible for a PPI based on these guidelines, receiving aspirin monotherapy or any combination therapy, who are at high risk of GI bleed. Now, a new section that has been added to the guideline is the quality control and quality indicators. Of course, it is very important, but I would also caution that the management should not be just about ticking columns on a pro forma. So we have to think and individualize patient treatment based on the patient characteristics. For example, a patient with an ECG like this with cross ST depression and all leads except AVR showing ST elevation, naturally it is a high risk patient regardless of whatever scoring systems you use. Similarly, just like deserving patients should not be denied proper treatment, we should try to avoid inappropriate thrombolysis, because this is data from Kerala in 2013, staggering. Like it's 19% inappropriate thrombolysis in NSTEMI. So we should try to avoid thrombolysis. In fact, these patients had higher hospital mortality and MACE rates. So to conclude, the approach to NSTE ACS should be patient-centered. We have to incorporate the guidelines into clinical practice depending upon the disease characteristics, the center and the facilities where we are working, the socioeconomic status and the comorbidities of the patient. Surely incorporate the COVID status currently into the management algorithm, and at least some far corner of our mind try to keep the medico-legal aspects also, and a bit of common sense and some other factors like naturally management may change. It's not like STEMI, where STEMI immediately say the primary PCI or thrombolysis. Here there is a bit of a gray area, and which can be influenced by a human element, whether it is day or night, what is the cath lab status, is busy, what is the expertise of the operator after the angiography. So all these factors may come into play. So thank you once again to team KMC for this invitation. Let's hope that I would like to confess that I missed two things very sorely. One is the extraordinary dishes at MANIPAL, and second, your affectionate hospitality. Hope we can get that next year. Thank you so much.
Thank you very much. That was Dr. Sajan Ahmad from Tiruvalla Pushpagiri Medical College talking on the management on non-ST elevation MI. Dr. Sajan, nice to have you with us. I would like to ask you, with these new 2019 ESC guidelines, have you changed your practice after the new guidelines have come up?
Yes. In fact, if you take COVID out of the situation, if you consider a pre-COVID era of management, usually unless the patient has got ongoing ischemia or is hemodynamically unstable or is having a significant arrhythmia, the practice would be to stabilize initially and do an angiography within 24 hours. So usually if a patient comes in the morning itself during the daytime, we may prepare the patient and take him up for an angiography maybe by afternoon or evening. But if the patient comes at maybe 7 p.m., patient is relatively stable, he had chest pain 5 hours back, now he doesn't have chest pain, BP is stable, no arrhythmias, so then we may post him as a first case on the next day. So I think it is not a very homogeneous population as in the case of STEMI. There are a lot of, and most patients are, I think with the pattern that we see here, they are older, they have more comorbidities, they sometimes turn out to be patients, more often turn out to be patients with multivessel disease. And so I think we need not have a knee-jerk reaction to NSTEMI and take the clinical presentation into consideration and do what is right for each individual patient.
That's wonderful. Thank you very much for your wonderful presentation. I know you could make any boring subject interesting with your addition of extra slides and extra pictures, just like your dad. We really enjoyed your talk and your company, and hopefully next year we'll meet again for the same conference. Thank you very much.
Good night.
Good night.
Good night.
We would move to our next speaker, Dr. Nitin Kansal, who will tell us about atrial fibrillation, what is new. Dr. Nitin Kansal from Jaipur.
Good evening. At the outset, I would like to thank my alma mater for allowing me to be a part of MANIPAL Update 2020. And the topic on which I'm going to speak is what is new in atrial fibrillation in 2020. And my topic is totally derived from the latest publication of ESC guidelines for the diagnosis and management of atrial fibrillation by the European Society of Cardiology. Now, the class of recommendations and the level of evidence is well known to everybody, so I would not go into it. Definition of atrial fibrillation. We all know it's a supraventricular tachyarrhythmia which needs to be documented on a 12-lead ECG for at least 30 seconds, and it should show a irregular RR interval, absence of distinct repeating P waves, and this should be definitely for at least 30 seconds on an entire 12-lead ECG. Atrial high rate episodes are important because they are used to diagnose subclinical atrial fibrillation, especially in patients who have CIEDs like pacemakers, defibrillators, or implantable implantable loop recorders, and these help us in identifying patients with subclinical AF, and it is important for decision making for whether they need to be on oral anticoagulants for thromboprophylaxis. Now, definition of atrial fibrillation: it is diagnosed as first diagnosed irrespective of its duration or the presence or severity of the AF related symptoms. If you have seen the patient for the first time and he has never been diagnosed to have AF earlier. Paroxysmal atrial fibrillation is anything that lasts less than 7 days, even if it is terminated within 7 days by intervention. Persistent atrial fibrillation is something that lasts more than 7 days and less than 12 months. And long-standing persistent atrial fibrillation is anything that lasts for more than 12 months, although a decision on rhythm management is still on. If the decision has been made that the patient would have to stay with atrial fibrillation and only rate control is the option, then it becomes a permanent atrial fibrillation. The terminologies like lone atrial fibrillation, valvular, non-valvular atrial fibrillation, and chronic AF should not be used and should be abandoned. This I've already described how to diagnose atrial fibrillation, and this is a class 1 indication. And once the diagnosis has been made, initial assessment for stroke risk, symptom status, burden of AF, and evaluation of substrate should be done based on age, genetics, ethnicity, male sex, and all other factors that can lead to increased hypertension, increased atrial fibrillation, in addition to the factors which can cause increased risk for stroke should all be looked at, and based on that we should decide whether the patient should be taken up for further screening of atrial fibrillation. Once the decision has been taken that this patient needs to be taken up for screening for atrial fibrillation, it should be clearly described to the patient what is the significance and treatment implications if AF is detected, and a structured referral platform should be in place in all the institutes. Definition, of course, we have already described it twice earlier, and this is a class 1 indication. Various systems that can be used for screening atrial fibrillation have been shown here, and each one of them have their own benefits, and they should be looked into before deciding on which parameter is being used for screening the patient. Once the patient has been diagnosed atrial fibrillation, then an integrated AF management is what we need to look at, and this should be patient-centric. The most important aspect is optimized stroke prevention, following which the symptom control with rate or rhythm control and management of cardiovascular risk factors come in, and this includes lifestyle modification and psychosocial management. You can clearly see here that integrated management of atrial fibrillation does not only involve a cardiologist, but involves many other specialities, including people who are not a part of the clinical spectrum, like pharmacist and AF nurse. Although these are more applicable to the Western world, but definitely many centers in India are also looking at managing patients in this way. So integrated AF management is class 1 indication, and all these PROs should be in place when you are doing atrial fibrillation management. Once the AF has been diagnosed, the first and foremost thing that we need to do is thromboprophylaxis. And in this, we need to not only look at the CHFrecEF score, but also Hasbled score should be looked at, and modifiable bleeding risk factors should be looked into, based on which the management of the patient should be done. The initial decision, if taken for oral anticoagulation, should be relooked at regular intervals, and this is a class 1 indication. In this slide, you can see that there are non-modifiable, modifiable, and potentially modifiable factors which need to be looked at, because these can increase the chances of bleeding in a patient. And once you have diagnosed or identified potentially modifiable or modifiable risk factors like hypertension, excessive alcohol intake, bridging therapy with heparin, or extreme frailty, anemia, these should be aggressively managed to decrease the risk of bleeding, so that the patient can be managed on oral anticoagulation for a better stroke prevention. So, decision of stroke prevention has been taken. Look at whether the patient has prosthetic mitral valve or moderate to severe aortic mitral stenosis, and put them on VK if yes. If no, look at the CHFrecEF score. If it is less than 0 in males and less than 1 in females, they do not need antithrombotic therapy. Relook at the spectrum after, let's say, 5 to 6 months, and then decide whether they need to have it in future. If they have a CHFrecEF score of more than this, then look at the Hasbled score and the modifiable bleeding risk factors, work on them, and then start on NOACs, which is a class 1 indication, especially if patients have a CHFrecEF score of more than 2 or more than 3. I would say anybody who has more than 1 in males and more than 2, I would possibly go for NOACs in those patients. So, what you can clearly see is that 4 to 6 month revisiting of the CHFrecEF score is a class 2A indication, and estimated bleeding risk in the absence of absolute contraindications to oral anticoagulation should not in itself guide treatment decisions. Clinical pattern of AF does not decide thromboprophylaxis. It is class 3. It is only the CHFrecEF risk score based on which you should always decide whether the patient needs a thromboprophylaxis. Prior to cardioversion, what all things we need to look at is first that the patient, if he has hemodynamically stable atrial fibrillation, then he should be cardioverted only after considering the thromboembolic risk. And if the patient has sick sinus syndrome, atrioventricular disturbances, conduction disturbances, or prolonged QTC, pharmacological cardioversion should not be tried on them. Now, catheter ablation. This is something very important and very aggressive in Western world. So what are the indications for catheter ablation for rhythm control? This should be, first of all, decided after a detailed discussion with the procedural risk and major risk factors having been looked into, and the patient needs to be explained in totality about the procedure. And this is a class 1 indication. Repeated PVI procedures and procedure of atrial fibrillation ablation in patients who have failed a therapy of antiarrhythmic drugs, it is a class 2A indication to do a AF ablation. You can see in persistent atrial fibrillation, it is a class 2B indication, and additional lines or other fragmented activity or ectopic rotors to be targeted is again class 2B indication, and they are still not very much things which need to be propagated. So indications for catheter ablation of symptomatic atrial fibrillation, you can clearly see, first of all, the patient needs to be explained about the choices, and only after failed drug therapy it becomes a class 1 indication in paroxysmal or persistent atrial fibrillation. In patients in whom there is a heart failure and tachycardia cardiomyopathy is a possibility, in that is the group of patients, it becomes a class 1 indication to do a catheter ablation after explaining the choice to the patient. Else, if the patient refuses, you can go for antiarrhythmic therapy, and if that fails, you can again go for catheter ablation. So class 1 indication is only if you are thinking of tachycardia cardiomyopathy with atrial fibrillation, or if the patient has antiarrhythmic therapy, at least one set of drugs. Lifestyle modification is a part, and avoidance of triggers is a part which needs to be aggressively looked at and taught to all the patients, and this is a class 1 indication. Now, stroke risk management, pericardioversion, you should look at the NOACs as should be on board before cardioversion, especially if it is more than 24-hour AF duration. The patient should be on anticoagulation for at least 4 weeks and should continue it for another 4 weeks post-cardioversion. I have already talked about lifestyle modification. It is class 1 indication, and this includes aggressive treatment of hypertension, hyperglycemia, stopping smoking, alcohol, physical activity needs to be increased, obesity and obstructive sleep apnea should be looked at with aggressive management. If the patient has atrial fibrillation of less than 24 hours and his STAT-SVASC score is less than 0 in men and less than 1 in women, then the post-cardioversion anticoagulation may be omitted, but it is class 2B. So for all practical purposes, I would anticoagulate a patient post-cardioversion for 4 weeks, whatever be his STAT-SVASC score. Recommendation for stroke risk prevention in pericatheter ablation procedures, you have to have the patient on oral anticoagulation for at least 3 weeks before ablation, or else class 2A, you can look at transesophageal echo and exclude LA thrombus before ablation. But the patient should be on NOACs preferably, and the ablation procedure should be done without interrupting the OAC, and this is class 1 indication. The patient should be on oral anticoagulants for at least 2 months post-procedure. Now, long-term antiarrhythmic medications, sotalol should be used only if we can closely monitor the QT intervals, serum potassium levels, and creatinine clearance. In patients who are on flecainide, AV nodal blocking drug should always be added, and this is a class 2A indication. So when you look at long-term rhythm control using medications, you can clearly see if the patient has no structural heart disease, possibly drugs other than amiodarone should be used because of the side effects of amiodarone. But if the patient has heart failure, significant valvular disease, flecainide is out, you cannot use it, and amiodarone is in. But patients who have reduced ejection fraction, you only have an option of amiodarone or catheter ablation, especially if you think that the patient has tachycardia cardiomyopathy. This is very important. A very important subgroup of patients of atrial fibrillation who have ACS, a PCI or a chronic stable angina is present. In these group of patients, it is a very well documented guideline now that the patient should have triple therapy for at least 1 week. And at that point of time, a decision on whether to stop aspirin can be taken, especially if the bleeding risk is very high and thrombosis risk is low. else it should at least be continued for 1 month, following which a NOAC plus a P2Y12 inhibitor can be continued for 6 months to 12 months based on the risk profile. If the patient only had fibrinolysis done, then aspirin is out and the other thing pretty much remain the same. Similarly, if the patient is on VKA, then INR should be maintained between 2 to 2.5 and rest of the therapy is the same as I had described for NOACs. Before deciding on triple therapy or double therapy, we need to look at the thrombotic risk factors and the bleeding risk factors and weigh them accordingly. And based on these two, you should actually decide. And of course, the access site bleeding or access site is also important. And based on these parameters, one should decide whether the therapy needs to be continued for 1 week to 1 month, triple therapy, I mean, or double therapy for 6 months to 1 year. So at the end, I would basically like to conclude by bringing out the differences between the 2016 and 2020 guidelines. The first difference is that the integrated AF management has been upgraded from class 2A to class 1, where we need to have a good understanding of how to manage the AF as an integrated approach involving multiple departments and having it as patient-centric approach. Bleeding risk assessment with identifying modifiable, non-modifiable or partially modifiable risk factors have also been upgraded from class 2A to class 1, and their attention to them needs to be looked into. Thromboprophylaxis using NOAC has been made class 1 from class 2B, and if NOACs cannot be started, then TTR should be improved in patients who are on BKA. AF catheter ablation has become class 1A indication from class 2A indication, and the indications in which it is specifically class 1, I have already described them during the previous slides. Of this, I have already described that the patient having tachycardic cardiomyopathy, it becomes a class 1 indication to go for catheter ablation for rhythm control. Complete isolation of pulmonary veins is class 1 indication. Doing a CTI ablation is if the patient had a documented flutter has been downgraded from class 2A to class 2B. That means it may or may not be considered to be done. Weight loss has been upgraded from class 2A to class 1 and has been included in the integrated approach, where NOACs recommended with at least efficacy and safety as warfarin before a cardioversion has also been upgraded to class 1. After AF ablation, I have already described that 2 months of post-ablation NOAC has to be continued, and this has been made as class 1 indication. And long-term continuation of systemic anticoagulation does not depend on the success of the procedure. It basically depends on the CHATS-VASC score. If the CHATS-VASC score is high, the patient, even if he remains in sinus rhythm post-ablation, he should be on NOACs for life. Long-term antiarrhythmic therapy, amiodarone is possibly the therapy of choice for most of the patients except the ones who have no structural heart disease, in whom other drugs may be tried, but if nothing works, then amiodarone is the go-to drug in any case. Attention to good blood pressure control has been upgraded to class 1 from class 2A, whereas physical activity has been downgraded from class 1 to class 2A. But I do think that physical activity management is also important. Obstructive sleep apnea management has been downgraded from class 2A to class 2B. And for stroke prevention, especially in patients who have had ICH, detailed discussion with neurologist or stroke specialist should be done, and these patients should be started on NOACs to decrease the chances of intracranial bleeds. This has been upgraded from class 2B to class 2A. Long-term oral anticoagulant therapy to prevent thromboembolic events may be considered in patients who have had post-operative atrial fibrillation after cardiac surgery, and this also again depends on the CHATS-VASC score, and this has been downgraded from class 2A to class 2B. Thank you. And I would like to point out here that these guidelines also say that beta blockers should not be used for AF prevention in as a pre-op medication for patients who are going non-cardiac surgery. Thank you. Thank you once again for inviting me for this talk.
That was Dr. Nitin Kansal from Jaipur for the wonderful talk. Thank you, Dr. Nitin. I would like to ask you, in your practice, in your region, how do you choose between the 3 NOACs in stroke protection in AF patients?
At the outset, Tom, thank you for inviting me to be a part of this great conference, online conference. As an answer to your question, the first thing that you need to look at is how risky is, how much is the chance of bleeding in that particular patient? What is the risk of bleeding in that patient? So you have to look at the HAS-BLOOD score. The NOAC which has shown minimum bleed is actually Apixaban. Whether it is GI bleed or intracranial bleeds, Apixaban has been shown to be of greatest benefit as far as decrease in bleeding events is there. Stroke risk prevention, both dabigatran 150 milligrams and Apixaban were superior. So I don't see any difference between Apixaban and dabigatran as far as stroke risk prevention is concerned. But bleeding risk is definitely less in Apixaban. So my go-to drug most of the times is Apixaban, except in patients who cannot afford it as of now. In those patients, I definitely go for the generic brands of dabigatran. But they do come back with a lot of GI upset and increased bleeding, especially GI bleeds. Rivoraxaban has great, data on DVT prophylaxis and those kind of patients. So in them, I prefer Rivoraxaban. But otherwise, Rivoraxaban again has very high chances of GI bleeds, and so my go-to drug is always Apixaban.
Thank you very much. One more question. Has your practice changed over the last few months after the new 2020 guidelines have come? Keeping aside the COVID scenario.
Yeah. I mean, the atrial fibrillation ablation is something which is not very rampant in India. The main reason for that is the procedure usually needs redo procedures, either 1 or 2. Which most of the times people don't accept in India. They want a full and final therapy in the first procedure itself, which is usually something which we cannot offer in atrial fibrillation ablation. So even if it has become a class 1 indication to do an atrial fibrillation ablation, especially in tachycardia cardiomyopathy patients, my practice has not changed because I have not been able to convince my patients to get an atrial fibrillation ablation with chances of getting a redo procedure done. Otherwise, the NOACs have definitely picked up significantly in last 2 to 3 months, especially with the COVID scenario. It has further because thromboprophylaxis has been used even in post-COVID patients. So definitely NOAC use has definitely gone up.
Thank you very much for your wonderful presentation. That was Dr. Nitin Kansal from Jaipur. Thank you very much.
Thank you so much.
We will move to our next presentation, Dr. Govindanuni from Jubilee Mission Medical College, Trichur. He will be talking to us on the topic anticoagulation in COVID-19, a cardiologist's perspective. Let us listen to Dr. Govindanuni.
My dear friends, my topic today is the role of anticoagulation in COVID-19 from a cardiologist's perspective. Now, before I start, I have to say one of the important things which is essential in the present fight against COVID-19 is humility, because we hardly know anything about this disease, and this disease is yet to be of age. It is still in its infancy. And the thromboembolic problems with COVID-19 has been described maybe only 6 months ago. So there are a lot of things which we do not know. In fact, there are more things which we do not know than the things which we know. So humility is essential in the fight against COVID-19. In fact, a new terminology has been described, that is COVID-19 associated coagulopathy. SARS-CoV-2 virus does not have any intrinsic procoagulant effects either. So that is not the cause of the coagulopathy. And it is also distinct from disseminated intravascular coagulation because the major finding in COVID-19 is thrombosis, whereas the major finding in DIC is bleeding. Also, in COVID-19, the typical findings are a high fibrinogen level and a high factor 8 activity, suggesting that there is no major consumption of coagulation factors, which is opposite to what happens in disseminated intravascular coagulation. So the present concept is that the coagulation test abnormalities in COVID-19 is a result of profound inflammatory response. Most COVID-19 patients would not be classified as DIC according to the DIC score of the International Society on Thrombosis and Hemostasis. So let us see what are the major characteristics of the COVID-19 associated coagulopathy. Well, one, coagulopathy is manifest as elevated fibrinogen, elevated D-dimer, and minimal change in prothrombin time, APTT, and platelet count in the early stages of infection. In fact, the levels of fibrinogen are directly related to the level of inflammation as marked by interleukin-6 levels. So coagulopathy is definitely related to the inflammation. Coagulopathy appears to be related to the severity of illness and resultant thromboinflammation and not intrinsic viral activity. Many times the coagulopathy comes after the patient becomes negative for virus. So it is inflammation which is the result of this coagulopathy. And rising D-dimers, elevated D-dimers are an important marker of the coagulopathy. Elevated D-dimer at admission is associated with increased mortality. And during hospital stay, as the D-dimer rises, rising D-dimer after admission precedes multi-organ failure and overt DIC. So there is also an element of DIC, even though the major contributor is not DIC. Now it is noted that the D-dimer starts rising from about 4 days after admission in non-survivors, and the longer the duration of hospital stay, there is increasing D-dimer and more is the chances of developing sepsis physiology. Fortunately, however, bleeding manifestations are not common despite the coagulopathy. Now, there are other problems also. There are so many investigational therapies for COVID-19 now, even though many of them has not really been successful. The problem is that some of these investigational drugs have clinically important interactions with antiplatelet and anticoagulant agents. I can just show you a chart that have effect on antiplatelets, another group of drugs which have effect on anticoagulant. I'm not going into that one by one for want of time. Now, to look at the prevalence of arterial and venous thromboembolic complications, probably this is the best registry. This was published very recently in the JACC, Journal of the American College of Cardiology. What they found was that at 30 days from the diagnosis, in the ICU cohort, they have only looked at the ICU cohorts, the major arterial or venous thromboembolic events was 35.3%. In other words, 1 in 3 of ICU people developed either arterial or venous thromboembolic events. Major adverse cardiovascular events, which is cardiac death, non-fatal MI or non-fatal stroke, occurred in 45.9%, which means it's just less than half of the population. And symptomatic venous thromboembolism was there in 27% of patients. Most of these patients, most of these events occurred during hospitalization. As you can see, 98, 97 and 97% respectively occurred during hospitalization. So it is the hospitalized patient who is at the highest risk of thromboembolisms. And this is very important, that they found that the symptomatic DVT was largely composed of catheter or device related thrombosis. So when you put a catheter or a device in a patient with COVID-19, make sure that it is essential. Unnecessary catheters or unnecessary devices can lead to symptomatic DVT and hence problems. Now, if you look at those patients in the ICU, whereas those patients who are inpatient inside the hospital but out of ICU, one can find that the cumulative proportion of arterial and venous thromboembolism is much higher in the ICU, which is the red line, compared to inpatients who are not in the ICU. This is also true for major cardiovascular events. Again, you can see that the proportion of patients without major cardiovascular events, the red ICU, is much, much less compared to those in patients without, in the non-ICU setting. So the registry sums up being that in COVID-19, major or venous thromboembolism occurs in ICU patients compared to 6.1% in the hospitalized non-ICU patients. And symptomatic venous thromboembolism occurs in 27% of ICU patients compared to 2.2% of hospitalized non-ICU patients. And remember, this happens despite 85 to 90% of thromboprophylaxis rate. This, as I said, is a very recent registry. And so the vast majority of it were already on thromboprophylaxis. Now, a word about venous thromboembolism. The frequency of venous thromboembolism, as we have seen, is highest in the setting, being around 25 to 27% when you consider symptomatic disease. However, if you do a routine surveillance by venous ultrasonography of all patients, the incidence of VTE rises to 16%, quite significant, almost two-thirds have venous thrombosis if you go by a venous ultrasonography. And the other difference is that in general, in a sick patient, non-ambulant patient, when we talk about pulmonary embolism, we mean that there is thrombus formation in the deep veins of the legs or pelvis or arms, and then they embolize into the pulmonary circulation. But in COVID, what is found is that local thrombi are formed in the lung vessels due to local inflammatory process. So it is more of a pulmonary thrombosis rather than pulmonary embolism. Now, if you look at the relationship between anticoagulation, mortality, bleeding, and pathology among hospitalized patients, this is again from the US, a single health study, again published very recently, hospital mortality with a significant p-value. Prophylactic anticoagulation says the same thing. There is a lower hazard of mortality, again, statistically significant. Anticoagulation was also associated with a 31% reduction in the hazard of intubation, p-value being 0.02. And prophylactic anticoagulation was similarly associated with a reduced incidence of intubation. So you can see that anticoagulation, whether therapeutic or prophylactic, is not only associated with a reduction in mortality, but is also associated with a reduction in the risk of intubation. Bleeding rates were low overall, unfortunately, but as expected, it will definitely be slightly higher in the therapeutic anticoagulation group compared to the prophylactic anticoagulation group, compared to no anticoagulation group, as is expected. Now, let us see what we should do when a patient comes with COVID. Routine testing of all patients. Well, when the patient is hospitalized, all inpatients should have these tests: a complete blood, including count, coagulation studies, prothrombin time and APTT, fibrinogen, and TAVR. And from this, we get the classical picture of COVID-19 associated coagulopathy, which is a high D-dimer, a high fibrinogen, normal or mildly prolonged PT and APTT, mild thrombocytopenia or thrombocytosis, or normal platelet count. It must be remembered that patients who are not hospitalized, for outpatients, there is no requirement for routine anticoagulation testing. Now, there are also other abnormalities in COVID-19 like raised LDH, increased lactic dehydrogenase, and strikingly high ferritin concentrations. reminiscent of findings in thrombotic microangiopathy. This is very important because ferritin is also an inflammatory marker, and you can see very high ferritin concentrations. And so there are now a consensus of opinion. Many people believe that coagulopathy associated with COVID-19 is a combination of low-grade DIC, localized thrombotic microangiopathy, and that is the reason why ferritin levels are very high. Moreover, interleukin-6, which is again another inflammatory marker, can induce tissue factor expression on mononuclear cells, which subsequently initiates coagulation activation and thrombin generation. Now coming to prophylactic anticoagulation. In late March, the International Society on Thrombosis and Hemostasis recommended that all hospitalized COVID-19 patients, even those not in the ICU, should receive prophylactic dose of low molecular weight heparin unless contraindicated. Among nearly 3,000 patients with COVID-19 admitted in the New York City's Mount Sinai Health System beginning in mid-March, median survival the results particularly striking by prophylactic anticoagulation, and the median survival jumped from 9 days to 21 days. Now this association with anticoagulation and improved survival remained even after adjusting for mechanical ventilation. Of course, one has to pay a price, and the price was hemorrhagic stroke, which was significantly increased with the use of anticoagulation, but still was reasonable and not very high. So let us look at the management strategy in patients with COVID-19. Well, we will divide patients into outpatients and inpatients, and inpatients are further divided into those in the ward and those in the ICU. Those in the ICU we have divided into 3 groups: confirmed venous thromboembolism, presumed pulmonary embolism, and patients with ARDS. Well, all inpatients should have the coagulation test, which I mentioned earlier has to be done, whereas in the outpatient setting there is no need for coagulation tests. Now, prophylactic standard dose vitamin venous thromboembolism should be considered in outpatients if they are high risk, like obesity or bedridden or something like that, or past history of venous thromboembolism. But it should definitely be given in all inpatients admitted to the ward. This is standard prophylactic venous thromboembolism dose of low molecular weight heparin. Now, when you consider escalated dose of VTE prophylaxis, now VTE prophylaxis dose they have divided into standard dose, escalated dose, and therapeutic dose. The escalated dose, which means higher than the prophylactic dose, should be given in all patients admitted to the ICU, especially those who are having signs of adult respiratory distress syndrome. And finally, you give therapeutic dose anticoagulation in patients with either confirmed VTE or presumed pulmonary embolism. Now, what about post-discharge? Extended post-discharge VTE prophylaxis. Well, extended can be given with either low molecular weight heparins or with a direct oral anticoagulant. There is no data specific to COVID-19 so far. As I said earlier, we really do not know what is the protocol, what should be the protocol. But stratify the patient individually for both thrombotic and hemorrhagic risk, and give extended prophylaxis for 45 days for patients with elevated risk of venous thromboembolism. For example, reduced mobility, comorbidities such as cancer, or D-dimer more than 2 times the upper limit of normal, and of course, patients who have low risk of bleeding. Now, what about patients who are quarantined with mild COVID-19, not hospitalized, but they are quarantined? Well, these patients, thromboprophylaxis is indicated in those with significant comorbidities, not routinely, only those with comorbidities, which makes them at risk for venous thromboembolism. Uncertain in patients without COVID-19. If you are just quarantining with suspicious COVID-19 or because he is a primary contact, it is really uncertain unless they are less active because of quarantine. So what should be done is to advise these patients to stay active at home. Even quarantine patients with mild COVID-19 should be advised to stay active so that you can avoid venous thromboembolism prophylaxis. In the absence of high quality data, the current concept is that pharmacological prophylaxis should be reserved only for those patients at high risk. So not routinely. It should not be given routinely, including those with limited mobility, history of prior VTI or active malignancy. So only these patients should be put on pharmacological prophylaxis in quarantined patients with mild COVID-19. Now coming to arterial thrombosis, let's deal with STEMI and COVID-19. Whatever data we have with STEMI and COVID-19 shows that in STEMI in patients with COVID-19, there is higher incidence of multiple extensive arterial thrombosis also. There has been need for increased use of GP2B3A inhibition and thrombus aspiration. And it has been found that the levels of D-dimer correlates with the thrombus grade, correlates with the myocardial blast grade, and correlates with the level of heparin requirement during the primary PCI procedure. So you can see it here. This is again JARC data. In-hospital mortality is higher for COVID-19, but you can see that the p-value is not significant. Intensive care admission is higher for COVID-19 and the p-value is significant. And admission length for COVID-19 patients with STEMI is also higher, and you can see that it's a significant p-value also. Stent thrombosis is higher with STEMI and COVID-19. Again, you can see the significant p-value. Multivessel thrombus is much higher in patients with STEMI and COVID-19. And modified thrombus grade 4 and 5, higher thrombus burden, is also seen more commonly in patients with STEMI and COVID-19. And it translates to lower patients. Maybe in the mild COVID-19 patients, in the very mild patients who are active, you need not give VTE prophylaxis. But the consensus is that most patients, especially if they are hospitalized, should be on VTE prophylaxis. And the dose of VTE prophylaxis, whether you should give standard doses or escalated doses, will depend on the potential for increased risk of VTE and adverse outcomes, which are determined by age, bedridden status, stasis, inflammatory response, level of IL-6, for example, endothelial injury, hemostatic abnormalities like D-dimer, and evidence of DIC. So I conclude with that, and thank you very much for this opportunity. Thank you.
Thank you very much. That was Professor Govindanunni from Jubilee Mission Medical College, Trichy, on his perspective of COVID-19. I would like to ask you, in your region, how do you manage an ST elevation MI with COVID positive status?
Thank you, Tom. First of all, thank you for calling me for this great event. I would have loved to come to Manipal and relive nostalgia, my good old days. But of course, maybe we can have it next year. Well, what we do for STEMI nowadays is that we sent the RT-PCR sample for all patients with COVID, all patients who come with the STEMI, but we really do not wait for the results. We go ahead with the STEMI, with the primary plasty, with all precautions, with full PPE suit for everybody, for technicians, anesthetists, everybody. and then keep them in one part of the ICU, which we have reserved for these patients till the results come. Once the results come, we shift it to the normal ICU. Whereas an NSTEMI patient, we wait. As the sergeant said, we can really afford to wait for these patients. So if they are hemodynamically stable, we wait till we get the results of the COVID-19. The problem with STEMI is that if you thrombolize STEMI patients, many of the patients may actually not be having occlusions. It has been found that in COVID, many STEMI patients have normal coronary arteries. So thrombolizing may be worse than doing a primary angioplasty.
So let us say you do a primary PCI for COVID positive patient, and then as per the COVID guidelines, he is sick, he is in severe heart failure, and he needs anticoagulation. So how long do you continue with the anticoagulation, and which anticoagulation do you choose on discharge, and for what duration?
Yeah, as I already said, during hospitalization, in the hospital period, the best is to give low molecular weight heparin. Actually, heparin may be better because the renal failure and all those things will not affect heparin. But the problem with the heparin is that repeated blood drawing is required, which means you are exposing more technicians to the patient. So that way, guidelines say that you should go for a low molecular weight heparin, which does not require repeated blood transfusions. And at the time of discharge, again, there is no data, but the best possible option is to give a NOAC and continue for at least 45 days, and after that stop and give only antiplatelet drug, provided, of course, there is no atrial fibrillation.
Thank you very much. That was Professor Govindinoni from Trishur. Thank you, sir. Thank you very much. We hope to see you again next year.
Thank you very much.
Let us move to our next topic, imaging guided PCI in 2020 from Dr. Rajesh Vijayvargiya from Chandigarh. Let us hear it from him.
Hi, good afternoon, everyone. I'm Dr. Rajesh Vijayvargiya, Professor, Department of Cardiology, PCI Chandigarh. It's always a pleasure and honor to be there at MANIPAL University to attend the scientific session. I'm thankful to the organizing committee, Dr. Dev, Dr. Ganesh, and Dr. Rao for the invitation. With the ongoing COVID endemic, I could not come over there personally and could not enjoy the warm hospitality of the institute. However, it's very nice that the Manipal University has continued the trend of the annual meeting, and this time it's at the digital platform. It's my pleasure to give a talk on the topic which is assigned to me is imaging guided PCI, what is new in 2020. No conflict of interest regarding this particular presentation. As you all know about, there is a marked scope of imaging in a coronary intervention. You see the difference in resolution between, say, CT coronary angiography versus angiography, and a below diagram has very well shown the quality of picture of Mona Lisa. How does it improve with various investigation modality? In routine, we do use intravascular ultrasound and optical coherence tomography for the intracoronary imaging, and the resolution is markedly different between the two, IVAS versus the OCT. The later one do have around 10 times more resolution, though the penetration is on the lower side compared to intravascular ultrasound. The table did show the merit of various imaging modality which are commonly being used for the coronary intervention. So this includes the IVAS, virtual histology IVAS, angioscopy, OCT, and near infrared spectroscopy. In routine, it's IVAS and the OCT. IVAS do have less of resolution compared to the OCT, but more of the penetration. If you see the assessment of the lesion severity, it's always been better to have a functional assessment by FFR, but then IVAS and the OCT can very well give an idea about the percentage of stenosis one do have. Thin cap fibroathyroma can be very well visualized with the OCT. Identification of the necrotic core, it's the NIRS, it's the knee, which has more advantage compared to the routine angioscopy or the OCT. Optimization, which we routinely do use IVUS and nowadays with the OCT as well. And if you see the stent tissue coverage, it is very, very well defined, along with the stent edge dissection and malapposition, which can be very well visualized with the OCT. Assessment of the stent failure at follow-up can be assessed by both the modality, whether it's IVUS or OCT. Regarding few landmark trial which has given the edge of this imaging modality in coronary clinical event. Is the stent diameter bigger is better? Yes, that is then true. When we started using the intravascular imaging, this particular study has shown that with the end minimal stent area after the procedure, higher it is, less chance to have now in-stent restenosis. You can very well appreciate that the in-stent restenosis is lesser with the sirolimus eluting stent compared to bare metal stent in this particular diagram. So this is the advantage, that bigger the area and better the clinical or luminal outcome is going to be. So in terms of clinical outcome, it's a target lesion revascularization and means at follow-up, which is far better when the area is more than say 6 millimeters square compared to those with less than 6 millimeters square. This is the standard diagram which we routinely been used during the coronary intervention. So this is the IVUS guided stent area across the left main bifurcation, and it's the rule of say 5, 6, 7, 8 to have a minimal area at various sites, which include ostial LCX, ostial LAD, confluence of the left main and the left main shaft. So this is the minimum area which is required to have a successful PCI and also the good outcome. But it doesn't mean that you are not supposed to achieve the area which is bigger than this. So sometimes the vessel size is too large, and then you can achieve the area which is bigger than say 5, 6, 7, 8. Few of the trial regarding the OCT, which has recently been come into the picture. Element 1 was the initial trial, which has shown that okay, OCT is the one which is able to have the diagnosis of malapposition, under expansion, and the edge dissection, and it changed the stress the way the PCI operator do. It changed the decision making. Element 2 was the one where the OCT was compared with the IVUS, and then there was no significant difference between the two, but the stent expansion and stent malapposition was not, stent expansion basically was not properly assessed with the OCT compared to the IVUS, which was clarified in element 3, where the external elastic lamina based assessment was done, and it was found to be non-inferior to the IVUS guided PCI. It was also found that there is a similar degree of stent expansion and minimum stent area in both the arm, whether it is the IVUS or the OCT one. Element 4 is the recent ongoing trial, a multi-center, multinational trial which is going on, and the PCI is one of the center where the objective is to demonstrate the superiority of OCT versus angiography-guided PCI in those with a high-risk clinical characteristic and the high-risk angiographic lesions. As we all know, role of IVUS and OCT is there for stent optimization. It's a pre-intervention just to assess the plaque characteristic. For the post-intervention is the stent optimization, and at the follow-up, when there is the stent failure, one can have an idea about how the neointimal hyperplasia is there and what's the reason, whether it's a stent under expansion, malapposition, etc., which can be very well assessed by these two imaging modality. Something about say calcified plaque, which is very important for percutaneous intervention, the extent of calcification across the plaque, atheromatous plaque, can give an idea about which type of strategy you are going to use during the PCI. A low calcific burden, one can very well go with a direct stenting, a moderate calcification with a semi-compliant balloon, and those with a high calcium where the depth and length of calcium is too much, one has to have an adequate plaque modification by, say, scoring balloon, rotational atherectomy, and recently with the intravascular lithotripsy. So this particular study gives a scoring system for the extent of calcification, which can be very well assessed by the OCT. And this is the maximum calcium angle, which is a calcium arc in case it is more than 180 degree, thickness more than 500 micron, and length more than 5 mm. So these are the three criteria, including the 4 points. In case it's a 4 or more than 4 points of score is there, which means the rotational atherectomy. Those with a less than 4 score can be taken care by, say, scoring balloon or non-compliant balloon. Here I want to say that the depth of the calcification can only be assessed by the OCT, as IVUS doesn't penetrate beyond the calcified plaque, and therefore on the basis of the IVUS one can have an idea of the calcified plaque with its length and the arc of calcification. There is certain limitation about this scoring system because it cannot assess about, say, calcified nodule and its significance during the PCI. Calcified nodule are frequently being noticed in those with a chronic stable angina, but then daily it can be there with acute coronary syndrome as well. This particular case had an acute myocardial infarction and then had an unsuccessful PCI outside, been referred to my institute, and we had an OCT guided successful PCI using the rotablation. If you see the OCT picture, you can very well visualize the calcified nodule protruding into the lumen and creating the problem during the PCI, which were very well ablated with the rotational atherectomy. So this imaging to help to treat this subset of patient who do have say calcium seed and calcium nodule, where the therapy like rotablation, and then there is also a risk of, say, rotawire bias in such type of eccentric calcification, which can be very well assessed, and one can appropriately use either rotablation or IVL therapy in such type of lesions. This is the well-known diagram to have an idea about how the PCI optimization is being done. So minimal stent area should be, say, more than 4.5 to 5 millimeters square whenever you do put a stent across a major proximal coronary artery, and then the stent expansion should be at least 80 to 90% comparing the distal reference or proximal reference. The malopposition, which can be very well assessed with the OCT, should have less than 400 micron in the distance, and the length should be less than 1 millimeter. There should not be any thrombus or plaque protrusion across the stented segment, and this is very important that the plaque burden, which mainly includes the lipid pool, should be less than 50% both proximally and distally to prevent the geographical mismatch and the risk of, say, in-stent restenosis at follow-up. Regarding the SD section, it should be say less than 60 degree. It should not extend into the media. It should be intima base, and length should be less than 2 millimeter. In case this parameter is on the higher side, one need to put an extra stent across the edge of the previously deployed stent. So these are the various criteria which has to be used during the PCI optimization. So this is about certain recent advances regarding the, say, plaque modification by extensive drug therapy, which includes high dose of statin. One can very well assess the thickness. This particular case been taken from the net, where the fibrous thickness was 110 micron initially. With the aggressive lipid lowering therapy, the fibrous cap thickness increased to 320 micron at follow-up in the both IVUS and also in the OCT examination. So here, with the aggressive lipid therapy, one can very well assess how the atheromatous plaque with a high lipid content with high atheroma can regress at follow-up. In addition to the OCT or intravascular imaging, it's the near infrared spectroscopy which can very well clarify, like in the index case, which can be taken from one of the publication. The baseline FFR across the modality was 0.74 with the area of 5.6 millimeter square on the IVUS, which increased to 0.78, and also the area of 5.5 millimeter square following the aggressive lipid therapy. And then it's the spectroscopy, which gives an idea about the lipid core burden index, which has markedly decreased compared to the baseline. So drug therapy evaluation at follow-up can be very well assessed by the intravascular imaging. This is a very landmark trial, the PROSPECT trial, which has studied non-culprit lesion in patients with acute coronary syndrome who underwent 3-vessel gray scale and virtual histology intravascular ultrasound imaging after the successful PCI of culprit lesion. So mine over here, these were the lesions which were not significant angiographically. They had an FFR value more than 0.8, and then they were assessed with the intravascular imaging. And what it was found that those lesions, those insignificant lesions who had a clinical event at follow-up were the one who had a presence of thin cap fibroatheroma, a plaque burden which was more than 70%, and then the minimal luminal area of less than, say, 4 millimeter square. So this is a certain new area where one has to have an idea about which vulnerable plaque or which insignificant lesion is going to have a problem at future, can have a clinical event at the future, and they should be aggressively managed and treated at appropriate time. So regarding the clinical application near IVUS is that it's helped to identify and localize the vulnerable atherosclerotic plaque, which is a clinical tool and could help in precise lesion length, including segment with a lipid-rich core burden towards optimal stenting. As I initially mentioned, a less than 50% plaque burden should be there, but in case it is high lipid content and in case it is vulnerable plaque at the edge of the lesion, it should be well covered with the stent. The knee could provide about the information of the necrotic core of atherosclerotic plaque, which cannot be assessed with the IVUS or OCT, and can predict the embolization distally, resulting in slow or no flow phenomena, or can result into, say, peri-procedural myocardial infarction, which in turn is going to cause a high clinical event at follow-up. This new imaging modality is also going to be helpful to assess the possibility of future coronary event based on lipid content index of the non-culprit segment, and offer a unique diagnostic utility and a risk stratification tool for monitoring the effect of statin and also PCSK9 inhibitor in coronary vasculature. Regarding the role of imaging in the bifurcation, PCI, one of the meta-analysis which was recently published of 7,800 patients has found that there is a significant difference in the cardiac death between IVUS-guided PCI versus angiography-guided PCI. So imaging do help in improving the clinical event, including the cardiac death, in case it is to be used for bifurcation coronary PCI. It has also been found that those with a two stent, it is preferable and advisable to have imaging compared to, say, provisional stenting, where one can have PCI without the imaging. But note that imaging do always help. We do have enough data that shows that imaging always help to improve the clinical outcome and also the angiographic outcome in those patients who have a complex bifurcation lesion, left main lesion, and other complex lesion as well. We at the department, along with Ganesh, one of the organizing committee member, has studied the bifurcation coronary lesion, and that found that OCT2 helped to have an idea about, say, stent malopposition, which was found to be more frequent in those with the those bifurcation lesion where we had two stent stress A compared to provisional one stent stress D. Role of say contrast-free imaging. So there is a role of dextran, and our department has published a paper regarding use of dextran during the OCT to reduce the contrast load, which is of course required in those patients who have LV systolic dysfunction or at the risk of contrast-induced nephropathy. So dextran in our experience is found to be equally effective with a good imaging quality as compared to contrast, and then this can be an alternative to contrast use in those patients where there is a limitation for high doses of contrast during the PCI. Another study along with the Army Hospital Delhi, which has been published in the Indian Heart Journal about the role of saline, and this is also found to be effective for adequate imaging of various lesion and stent optimization in the patient who require a less amount of, say, contrast during the percutaneous intervention. So at last, let me summarize. The intravascular ultrasound is in the picture since, say, 1998, when initial studies were started. It is in routine use from 2006, when ACCH has recommended that it's a class 2A indication for its use to an stent optimization. Recently, the ultimate study and IVS XPL study has shown that the MACE rate has a drastic improvement, a significant improvement following the use of IVAS during the coronary PCI. So it is preferable to use the imaging during the PCI when you are going to use the IVAS. Regarding the OCT, the thing got started in 2002 when it's been used in a human being, and then a frequency domain was started since 2008. The data are picking up for the OCT usage during the PCI, and following the Element 3 and the opinion trial, we have come to know that, okay, this is OCT is also comparable, at least non-inferior to the IVAS, and going to have improvement in the clinical outcome, though the angiographic outcome is found to be favorable. ESC guideline has again recommended 2A indication for the use of OCT during the PCI. So thanks for kind attention.
That was Professor Rajesh Vijayvargiya on recent advances in imaging in PCI. Thank you very much for the wonderful talk. I know you have been a big supporter of imaging, especially OCT, but I would like to know what % of your procedures you do OCT and what % you do IVAS.
So around 30% of my PCI patients undergo the intravascular imaging, and those patients who do has a large vessel size, left main bifurcation, I do prefer to go out for the IVAS, and rest of the patient it's the OCT which I do prefer.
So are there any particular scenarios where you have done both OCT and IVAS, and for what reason?
Yeah, I have done in a few cases that is only for the academic purpose. But then one of the imaging, either it's a OCT or IVAS, is sufficient enough to have a detailed study of an individual patient. So to have both the thing is most of the time is not required. It's only for the academic purpose.
Are there any particular incidences where you were forced to do procedure without additional imaging modality, and you had to think back and say, I should have used an additional imaging modality?
So I started imaging from say year 2011 onward, and then as my older patient of the PCI Do come, I have already reported late instant restenosis and also thrombosis, and could find out that, okay, these are the patients where the size of the stent was very undersized. And even recently I had a few publications internationally in Journal of Invasive Cardiology, where I had demonstrated stent structs uncovered stent structs even after 10 years of implantation. Though the incidence of say clinical event is too less, but then there are still few cases where you retrospectively feel like that these are the patients who should have been subjected for, say, imaging at the time of PCI. It is very frequent to come across those patients who do have, say, late stent thrombosis and late in-stent restenosis, both for drug-eluting stent and bare metal stent, where up to 70% of patients were found to have problem with undersizing of the stent, so which could have been corrected in case it has been prospectively used during the PCI.
Thank you, Dr. Rajesh Vijayvargiya. It has been great listening to your talk. We really appreciate the time you spend with us.
Thank you. My pleasure.
Thank you very much. We hope to see you here next year.
My pleasure, sir. Okay. Good day.
With that, dear friends, we come to the end of our nearly 4-hour academic discussion. It has been a pleasure being with you all. I thank all the speakers who have done a great job for giving these wonderful talks. I also appreciate all the delegates who has continued from the beginning and are still with us. That is itself an indication of the interest you have and the content of the lectures that the wonderful speakers have put forward. I also thank all my colleagues who have helped me in this, especially my dear organizing secretary, Dr. M. Sudhakar Rao, and Dr. Krishnanand, and our IT team, Arunachal and Mahendra, and all the students and colleagues of my department who has helped me in this program. Thank you very much. Have a wonderful evening. Goodbye from all of us here.